A very good evening. I, Dr. Hina Merchant Pandit, the organizing secretary of this CME on mood disorders in women across various lifespan, welcome you all for today's meet. This is a joint meeting in collaboration with the IAPP, Women Mental Health Committee, and the Bombay Psychiatric Society. I now welcome Dr. Rukshida Saida. She's the organizing chairperson of this event and request her to say a few words.
Thank you so much, Dr. Hina. Good evening, everyone. It's a pleasure to invite all of you all. This is the third annual event. Indian Association of Private Psychiatry shakes hands with Bombay Psychiatric Society, and this is the third year that we're doing this on women's mental health. We do this in March, towards the end of March usually, because by then a lot of us would have already celebrated, and towards the end of March we need to again get a reminder that why women's health and women's mental health is so important. On behalf of both the Bombay Psychiatric Society as a past TC member and Indian Association of Private Psychiatry as a current TC member and as a co-chair of the Women's Mental Health Committee, it's a great privilege to be able to organize this. And I thank at the outset Dr. Hina Merchant Pandit, who's been phenomenal at doing this with me, and she's been my partner in crime, though that would be actually giving out a wrong message because I've pretty much dumped everything on her. So the entire credit goes to her. At this point, it's Dr. Avinash D'Souza, who's the president of Bombay Psychiatric Society and also the general secretary of IAPP. He will be joining us shortly, and but on his behalf, it's a pleasure to welcome Dr. Priyanka Mahajan, who's the secretary of BPS, and you know that she's so dedicated because even while on a holiday, she's joined in, and she's going to share her comments and welcoming remarks with everyone. Dr. Priyanka.
Thank you so much, Dr. Rukshida. In fact, I'm glad that, first time I got a call from Hina ma'am and Rukshida ma'am, they're all my seniors, talking about this event. I was really excited because being a woman, I know how much women mental health means. And I'm very glad that Bombay Psychiatric Society and IAPP have come together to, speak on this very, very important topic. And we are very happy to see the number of participants because the number of queries we all have got are too many. And plus, this is an MMC credit point seminar. So I'm very glad, and I thank Dr. Rukshida and Dr. Hina to take up this important topic for every one of us. I will request Dr. Hina to please go ahead, and thank you everyone for joining, and thank you Dr. Hina and Dr. Rukshida for this noble initiative.
Dr. Mittal is there.
So Dr. Mittal hasn't joined us yet, but Dr. Anukal Mittal, he's a senior psychiatrist from Mumbai, and he's also the president of Indian Association of Private Psychiatry. He will join us shortly, and he's also going to chair a session. So we're definitely going to interact with him. And at this point, I would welcome Dr. Shashi Rai, ma'am. She's the chairperson of IAPP Women's Mental Health Committee, and Dr. Shweta Reddy from Hyderabad. She's the convener of the committee and a very hardworking girl. And Dr. Shashi Rai, ma'am, has always been very graceful, elegant, and very sweet and comforting and encouraging us all throughout all throughout so many years, really, and not just for the CME today. So I think, there are a lot of participants already joined in. And if we are ready with this first session, I think we could start that. But on behalf of IAPP, because Dr. Anukal Mittal will join us a little later, if I could please request Dr. Shashi Rai ma'am to give a few welcoming remarks.
Thank you, Dr. Rukshida. It's a real privilege to be on board on this program, and I thank the organizing committee, from IAPP, Dr. Rukshida and Dr. Hina, for having given me this opportunity. First and foremost, I wish everyone a very happy Holi on this occasion. And the topic, of course, mood disorders across the lifespan of women, it's very important. And as all of us do realize that women mental health is really important, and no health without women mental health. In fact, that is what we always say. So I welcome once again all of you. And the topics are very important. All the three topics for the three sessions are very relevant. And without wasting any more time, I can ask Dr. Hina to go forwards.
So I've just received our speaker, the speaker of the first session, Dr. Bhaskar's message, and he says that he'll take another 3 more minutes. Well, to all of us who know how Bhaskar is, well, this is absolute Bhaskar Mukherjee in his full Bhaskar mode. But yes, before we begin the first session, which is on neuroendocrinal impact on psychiatric conditions, I would like to welcome our two chairpersons for today, that is Dr. Heenal Shah Madam and Dr. Rajesh Jain. Well, all of us here know Dr. Heenal ma'am. I don't think she needs any introduction, but still I'm going to say a few words. Well, madam is a professor and head of the unit at the Department of Psychiatry at Nair Hospital, Mumbai. She has a degree in MSc in medical education and is the co-coordinator for GSMC FAMER Regional Institute. I mean, I'm not sure how many of us psychiatrists are actively engaged in the medical education part of it, but madam is one such person. She has been the past president of the Bombay Psychiatric Society, and her areas of interest include those on child and adolescent psychiatry and women mental health. I welcome you, Heenal madam. Our second chairperson for the day is Dr. Rajesh Jain. Dr. Rajesh Jain did his MD in psychiatry from CIP Ranchi and is practicing in the United Kingdom at the Avon and Wiltshire Partnership NHS Trust for the last 17 years. I welcome you, Dr. Rajesh Jain, sir. I request you, Heenal ma'am, now to kindly introduce the topic and our speaker, Dr. Bhaskar Mukherjee.
Thank you both, IAPP and Bombay Psychiatric Society, for making me a part of this, and you all have a track record of creating success stories every time. So kudos and more power to you for all the work that you all are doing. As already stated, that we all know the importance of women mental health, and also that the role of hormones and neuroendocrine, not only in women's mental health, but in psychiatry, is really a large piece of understanding. From the times when we initially talked of dexamethasone suppression test years ago to today, there has been a sea change of things that have come. Better understanding, more appreciation at the level of the second, not only at the level of the synapse, but beyond that at the second messenger systems. We have talked of epigenetics. We have talked of so many things, and hormonal interactions with all this is so important. Maybe the biological markers and precision medicine is yet round the corner, but there is so much more that has happened over the last few decades, and especially in the last few years, that it is very necessary to really update ourselves and be aware of all of this in the field of women mental health. And who other than Dr. Bhaskar Mukherjee to talk about this? He is a practicing consultant psychiatrist at Calcutta, firmly grounded in biological psychiatry, knows every nuance and understands that, and has been a live wire in the many of our organizations where we have all, including myself, have kept picking up understanding and tips from him to get better nuances and understanding of how biology works, how it interacts, and what it leads to disorders and their presentations. So it's a lovely pleasure to have him talk about this very significant part and make us more wiser in understanding it and then applying it along the way in our own practice. So has Bhaskar come in, or do we have yet time to wait for him?
He's joined, but ma'am, if I could just invite Dr. Anukant Mittal.
Mittal, yes.
Dr. Anukant Mittal, are you there, sir? If you could choose.
Yeah.
Yes. Sir, some welcoming remarks, sir.
As Heenal rightly said, I'll just put on my video here. An excellent team. I think it's one of the most active teams of IAPP, the women's mental health, and it is a burning topic now. In the pandemic, we have seen a lot of intimate partner violence, intimate partner aggression. We have seen a lot of problems for women, especially because they had to shoulder the burden of the family and also of everything else. And it is an issue which has been long neglected, and especially today's topic of mood disorders. I was told by my teachers that if an Indian woman comes to you for help and says she's depressed, she is severely depressed. Because an Indian woman, however depressed may be, will still try to be functional and not seek help unless she feels very desperate. And I believe that my experience of so many years is possible. Because women coming to me saying that she's feeling depressed, not able to function, or she's having mood issues, uh, the trouble must be severe. So I'm very thankful for Rukshida, for Henel, for everybody who has contributed to this. And I hope we go back home today with a lot more insight uh, from Bhaskar, from everybody else, from Shweta, everybody else who's there on the panel, Professor Vita Malhotra, Dr. Kashi Rai. We will learn from these great leaders. I think there should be a lot of men listening in on this, and I hope so. Thank you very much. Very nice.
Thank you, sir. Dr. Hina?
I am just waiting for Bhaskar to join. He's just messaged me saying that I'm joining in.
Yeah, he's just connecting. I can see him.
Yes, there he is.
You cannot miss that. The brain comes before anything else. That's the perfect introduction to Dr. Bhaskar Mukherjee. All right? Don't get it distracted anyway. Welcome, Dr. Bhaskar Mukherjee. I was just talking about you, and I said that one of the most important persons in psychiatry, and if I said biological psychiatry, he'll kill me because there is nothing but biological psychiatry. So let me not say anything more. Don't let me say any more adjectives except psychiatry, which of course is biological. And let me hand it over to him to give us some insights into this topic. All yours.
Thank you. And hello, everyone. Sorry, as usual, I always run late. Be it any appointment, you have to give me at least 10 minutes time that I would be joining either 10 minutes late or maybe even 20 minutes late. So sorry for keeping you waiting. I don't know what was talked about me, but let me assure you that I am just a psychiatrist, just a person who is a student of psychiatry, and I am just talking as another student with a group of students. So please don't think anything else. I am nobody special, nobody anything. I have to give this introduction because I don't know what these people have given my introduction as. But let me assure you, I am just a common person. So with that, we are coming to the neglected but very important topic of psychiatric symptoms and their interaction with brain in form of neuroendocrine symptom as well as neuroendocrine system, how neuroendocrine system can affect various psychiatric symptoms. You would think that psychiatric symptom means what? That thing is what we know as psychiatric diseases. They are not really diseases. They are just a group of symptoms placed together and formed into various nomenclatures, most of which share common pathophysiology, common molecular biology, as well as common neuroendocrine and immune pathogenesis. So standing there, I prefer to call them as symptoms rather than diseases. And so for the duration of this talk, when I am talking about psychiatry, I would talk about symptoms. I would not talk about the diseases because 1 hour or even 2 hours is very less when you talk about psychiatric diseases. With this forward, let's go back to topic for today's presentation. And the formal topic is neuroendocrinology and immunology of psychiatric symptoms in female. I was asked to give only view of neuroendocrinology, but problem is neuroendocrinology and immunology, these two are so interlinked that we cannot talk about one system without talking about others. So I have kept it as neuroendocrinology and immunology. But I can assure you, I would not bore. I would not bore you by talking about various molecular genetic stains and other things. I would try to give a clinician's perspective to other clinicians. This is the disclaimer. This is a scientific presentation, and for the purpose of this presentation, DSM, ICD, and other non-scientific methods don't exist. So forget DSM depression, forget DSM schizophrenia or ICD schizophrenia, forget bipolar, forget everything. Because if you focus on that, then this presentation would be very difficult to understand, because they don't exist for the purpose of this presentation. So what can we explore in this topic? Effect of brain on gonadal functions and resultant addition in systemic symptomatology of psychiatric symptoms in female. Means brain has the function of being the master organ in body. So it controls every organ, including gonads and endocrine system. So for that, every dysfunction involves gonadal dysfunction too, and due to that, every dysfunction syndrome of brain has a gonadal component, and systemic symptomatology of that dysfunction is influenced by gonadal dysfunction. And we can talk about that in details, but I am afraid that would take 7 days. So I'm not going into details of that. Now, effect of specific endocrine disturbances on women brain and their unique manifestation in females in form of different psychiatric symptoms, so-called myxedema madness or myxedema encephalopathy, so-called thyroid Graves encephalopathy, Graves psychosis, so-called Addisonian psychosis, Addison's disease and its brain manifestation, Cushing's disease and its brain manifestation and its unique presentation in female. Similarly, dysfunction of brain in every specific endocrine syndrome, be it pancreatic syndrome, be it syndrome of all GI neuroendocrine system or other system. But again, 1 hour is too late for that. Now, pregnancy and this neuroendocrinology affecting psychiatric symptoms in female. Another interesting topic on which we can deliberate and debate, specifically what treatment to be given or not to be given for another 1 month probably, but we don't have 1 month. Then neuroendocrinology of menarche and menopause and their effects on psychiatric symptoms in female. Perhaps a series of books can be written on this topic, but I hope to cover all this in 45 minutes and even less than 45 minutes because I don't have 45 minutes anymore. So I have to be precise and I have to give an overview if possible. So what really we are going to do is case-based discussion showing glimpses in each of these issues, or rather I am omitting menopause because that is going to be a huge topic. I would discuss other 3. I would talk about basic understanding, what went wrong in the management of the patients and what to do, or rather what I did. There are 1,000 other things that could have been done. I didn't do because I got result in these measures. But there are alternative actions that could be thought about and could be given. So without further beating around the bush, let's go back to the cases. The first case is, I have tried to give him some poetic name. This is the first case. Miss X, a 19-year-old student, presented to clinic with recurrent low mood and crying spells for last 9 months. She was taking medicine from another 2 psychiatrists and wasn't doing well. So she decided to change her doctor. On detailed inquiry, it was found that she had a withdrawn and obsessive nature since childhood, and she had multiple prominent phobias since that time. Multiple prominent phobias means she had fear of closed space, that is claustrophobia. She had fear of night, nyctophobia. She had fear of heights, acrophobia, and as well as she had fear of loud noises and people. Since her childhood, she was also very fearful of school and social interaction and was not doing good in the school. Then from her menarche, her symptoms evolved to include migraine and panic attacks along with premenstrual dysphoria and dysmenorrhea. Migraine attacks were more frequent during menstruation, and so we can say that there was catamenial migraine. In late adolescence, around 15 to 16 years of age, she also started menstrual irregularities, anger discontrol, and excessive indulgence to junk food, and obesity was also there. Her weight reached to 120 kg at the age of 19 years when she presented to me. 1 year back, she was taken to a gynecologist and was diagnosed as polycystic ovarian syndrome. She was taking 1.5 gram valproate, risperidone 2 mg, and lamotrigine 200 mg at the time of presentation for last 3 months, and was given 2 gram metformin by a gynecologist. This was the prescription with which she came to me. Now, she was still having profound sadness, profound lethargy, profound anxiety, and withdrawal symptom and other things. She has been given aripiprazole 10 mg and oxcarbazepine 900 milligram by another previous psychiatrist, but again that didn't suit with her. Specifically, she showed extreme akathisia with aripiprazole, and oxcarbazepine produced hyponatremia in her. So it was withdrawal. She has strong family clustering of diabetes, hypertension from mother's side, and malignancy from father's side. Mother had preeclampsia during pregnancy and gestational diabetes, for which she was treated, and the pregnancy, according to the mother, was uneventful. So what went wrong and how? Valproate induced PCOD in an unsuspecting child. This was the opinion of gynecologist. The gynecologist who was giving her 2 gram metformin. Her father was physician, and he opined that it is metabolic syndrome and PCOD due to psychiatric medication. Again, expected. Infant mental health clinic head, who frequently talks about infant mother diet and psychosocial intervention, would have commented on that she should have been given more priority in the diet, and she should have been given psychosocial interventions. But unfortunately, her physician father and multiple doctors in both of the family didn't really understand psychosocial intervention. So what to do? Any idea what has happened? I like to have interactions. I am not very keen on having a monologue. So any idea what has happened in this case?
So if I can just interrupt 1 minute, Dr. Bhaskar, I think the participants are on another link. There are more than 250 over
sorry.
there. There are
Sorry.
250 people there, but I think they're on a different link. So
Sorry.
I will try and post some of those questions here when you're interacting, but it'll take a little minute or two to get them to you interact across the different things.
Sorry, I actually didn't know that. No problem. So the monologue continues. Actually, this is a very complicated polygenetic picture presentation of polygenetic disease, or rather a polygenetic syndrome, because it has started in the brain, but it has involved whole body. The child had some inherited genetic disturbances in her brain, which made her vulnerable towards development of various cerebral dysfunction syndrome. Now, cerebral dysfunction syndrome can be divided into number 1, cognitive dysfunction, number 2, emotional dysfunction, number 3, motor dysfunction, number 4, sensory dysfunction, number 5, visceral dysfunction, and number 6, behavioral dysfunction. Now, this child is showing almost all the dysfunction. The metabolic syndrome, the PCOD is actually visceral presentation of brain dysfunction, and C is showing that since a long time. Why menarche changed the syndrome? Because during menarche, a lot of genetic changes have happened in our brain, and due to that, her brain started showing consecutive decrease in functioning more and more, resulting in increase in severity of symptoms. Her cognitive symptom is actually being expressed in form of academic dysfunction. Her emotional symptom is being expressed as low mood and irritability. Her sensory symptoms, which is not part of history, was tingling and numbness in various extremities. There was restlessness as well as lethargy as form of motor manifestation, and behavioral manifestation was the whole picture. Now, this is one of the pictures which explain the pituitary and growth hormone as well as insulin-like growth factor and ovarian interaction. This is how this thing causes polycystic ovary. But I would like to go to third picture first, because otherwise it is hard to understand this picture. There is a group of neurons in hypothalamus which are known as RFRP3 or gonadotropin inhibitory hormone neurons. They release RFRP peptide which inhibit GnRH neurons. They are stimulated via a lot of cues. One is metabolic cues, One is orexigenic neurons or NYP, I would like peptide cues. One is UMT cues. And they are also affected by adipose tissues and insulin and insulin-like growth factors. These neurons, when excited, they suppress gonadotropin release and they disturb the pulsatile gonadotropin release. This results in loss of pulsatile LH FSH release. Now, this would cause various changes in ovary. There would be increase in androgen. There would be steady rise of LH and FSH. There would be ultimately an ovulatory cycle and loss of menstrual regularity, and those those ovums which are not discharged from ovary, they actually stay in the periphery of ovary, producing polycystic ovary. This cycle can happen due to anything that causes brain to hyperact or brain to hyperactivate. That might be due to a genetic defect in brain, preventing brain from functioning fully. That might be due to anything in body, like a severe infection, severe fever, severe metabolic disturbances. That might be anything in surrounding environment that causes brain problems like grief or other various stressful situations. All of them can affect the gonadal cycle and produce polycystic ovary-like presentation. Similarly, this picture would also explain that how leptin and neuropeptide Y interaction can cause impulsive eating and ultimately obesity, as well as this picture can also give idea about how insulin-like growth factor and growth hormone disbalance can result in obesity as well as gonadal dysfunction. So each of these things are related, and brain dysfunction can and does present with various gonadal dysfunction syndrome in female. So standing there, what treatment was given to this girl? In first visit, she was given paroxetine in slow incremental dose up to 62.5 mg, propranolol 80 mg per day, and continuation of valproate and risperidone. Lamotrigine was stopped, metformin was continued, and patient was asked to review after 2 months. Paroxetine was increased by 12.5 milligram every 7 days to 62.5 mg. On fast review after 2 months, patient reported better mood control, less anxiety and panic attack. Rest of the cognitive and behavioral symptom was same as it was. In this visit, valproate was omitted and risperidone was replaced with cariprazine 1.5 mg. And she was given naltrexone incremental dose up to 100 milligram and again was called after 2 months. The rationality of naltrexone was naltrexone is a drug which suppresses, number one, the reward circuit hyperactivity. Number two, it also causes the motivation network overactivity to normalize. And along with that, the recurrent obsessive thoughts and imagery are also helped with naltrexone. Second follow-up saw are in much better shape. Impulsive eating has reduced and anger outburst has minimalized along with urge to has returned. But attention is still disturbed and weight and metabolic profile was not much improved. This time she was started on bupropion 150 milligram for 1 month and then 300 milligram along with semaglutide orally. Now semaglutide is a drug which is a intrathenomimide, or this is a drug which causes various changes in the body, which ultimately increases the glucose metabolism, adipose tissue metabolism, helps a patient lose weight, and also causes the brain to act less impulsively and also reduces the compulsive symptoms. This was given along with paroxetine, propranolol, and cariprazine, and she was called after 3 months. In third follow-up, she was almost normal. Started reading again with concentration, weight became normal, and her menstrual irregularities was gone too. Now she was sent to 6 monthly follow-up schedules. Current status, she is doing post-graduation and 1.5 years has passed since her stabilization. Now she is taking paroxetine 50 mg, propranolol 60 mg, semaglutide 7 mg, naltrexone 75 mg, and bupropion 300 milligram. Doing everything normally and having normal menstruation too. Her metformin was stopped, and the future plan is to keep her indefinitely to this regime, except propranolol, which would be omitted. And the future plan also include reducing semaglutide to 3 mg, because I hope most of you know that semaglutide for weight loss is actually API approved for 3 mg. She was given 7 mg because she had a severely high body weight. So after discussing with her family, this dose was chosen. But we have planned to reduce it to 3 mg in future. Now, the second patient, the killer pregnancy. Mrs. D, a 30-year-old home manager, presented to the clinic with 5 weeks pregnancy. This was her third pregnancy. The first 2 pregnancies ended in spontaneous abortions at 23rd weeks and 17th weeks respectively. She suffered from severe post-abortion psychosis and depression in second pregnancy. Now, I would like to clarify a fact that any psychosis and depression after abortion is similar to mechanism in postpartum psychosis. So ideally, any post-abortion psychosis and depression should be talked as puerperial psychosis or puerperial depression. But due to lack of our current understanding and our categorical system of seeing things, we make post-abortion psychosis and depression a separate thing, and we don't add that to puerperial depression. We should do that, otherwise we are going to miss a lot of puerperial psychosis and depression, which would result in future catastrophe. Like this patient, since her last pregnancy, she was suffering from recurrent depressive symptom, anger outburst, and paranoia, and was taking lithium 900 milligram, that is 450 milligram ISHAT, albuterol 20 mg, and lamotrigine 200 milligram. This pregnancy triggered a fresh depressive episode, and gynecologist was adamant about the supposedly ill consequences of psychotropic continuation. So the patient came as second referral to me. I was referred because I am good at fighting with gynecologists. So she was restless, anxious, was having multiple panic attacks, and had very severe suicidal ideation. And she was with a very valuable pregnancy. Her family history was significant in form of multiple past CVAs on maternal side of family. And along with that, there was also a few cases of AMI in the maternal family. Her elder sister died of abductio. She was assessed for hypercoagulability in just few weeks ago. Internist, and I would rather say a very knowledgeable internist, actually suspected hypercoagulability, and he fortunately tested for the thrombophilia panel, and she had Pi1-4G5G molybdenum. That means we are dealing with a patient that would go to either DVT or abductio at any moment. And on top of that, gynecologist doesn't want our drugs to continue. I was hoping for an interactive session, so I gave a comment, but no need to comment. So, with this case, we land to the minefield of fetal teratogenicity. Whenever we talk about teratogenicity, fetus, and psychotropic drug, huge problem occurs in the patient's family, in psychiatric fraternity, and in gynecology fraternity, because each one is almost sure that psychiatric drugs are the reason for all the problem in mother and baby. But that is not the case at all. Untreated psychiatric symptoms has a huge cost. How? Let me show you via this. Here, fetal teratogenicity means any ill consequences that is going to happen to a fetus. It in its broadest sense means if a child shows signs of autism symptom at 3 years of age, then that would be considered as one of the fetal malformation. I am talking about this broad sense. Now, if we talk about fetal developmental problems in all domain of function and physical body, then there are two sets of things that is responsible for it. Number one, maternal factor. Number two is fetal factor. The maternal factor is maternal immune system, maternal neuroendocrine system, maternal metabolism, and environmental insight. Let's discuss in details, in brief details about them. Maternal immune system determines how and when fetal implantation or implantation of zygote would occur in maternal body. If maternal immune system doesn't allow, then the zygote would not be implanted in uterus. And since zygote is a foreign body, maternal immune system needs to be relaxed to allow the zygote to implant. This is brain control, and brain control this thing via endocannabinoid and endo-opioid system. I don't know how many of you have heard about the name of leukemia inhibiting factor, LIF. LIF is one of the endocannabinoid, and it is found in brain and uterus both, as well as play a strong role in immune system, and this is one of the mediators of maternal receptive immune relaxation. Now, maternal neuroendocrine system also has a role in terms of the maternal neuroendocrine system proper, as well as placental neuroendocrine system. Their development depends on maternal genetic factor, fetal genetic factor, maternal immune system, and other things. Maternal metabolism would also have a very significant effect from maternal side, and environmental insult, any form of environmental insult, would change maternal immune system, maternal endocrine system, and maternal metabolism, and thus have an indirect effect. Environmental insult does not cause any direct effect except ionizing radiation. Everything else have an indirect effect through the
हाँ कल खा लूंगी मतलब है कि नहीं राइस कल सुबह राइस पूरा दही से बनाऊंगी
योगेश
दो
can I
तीन
ask you
कटोरी
to
चाहिए
mute
होता है
others?
फिर नहीं कल दो तीन कटोरी नहीं खा रही हूँ अभी रतन कल
Okay. Then, from the fetal side of contribution, there is fetal biparental inheritance of vulnerability to various dysfunction. Fetal biparental inheritance of various protective factors, which are again genetic. There are protective genetic factors, there are protective vulnerability genetic factors. Then feto-maternal microchimerism. I should talk about this because this is something which we need to know in details. But I would go that into further slides. And fetus spontaneous mutation. So all of these come together to form a complicated feto-maternal exchange at placenta with placental own contribution, and that causes teratogenicity. So standing there, nobody in any medical stream can say that this drug can harm fetus or this condition can harm fetus, because that is impossible. What we can definitely say is these drugs can help fetus, these drugs can help mothers, because to do deleterious effect, a lot of things are necessary. To do protective effect, just change of one of the harmful factor is necessary. So you see, whatever we give to fetus in pregnancy have a effect, but very complicated calculation system for it, and more often than not, the protective factor counts more than the damage factor. This is a very complicated picture. I was very skeptical of giving this picture, but I thought psychiatrists should see this. Otherwise, they would not understand that their fear is meaningless. They are probably helping the fetus by giving psychotropic, not harming them. And this picture would give them confidence. This is a picture showing the fetus and maternal exchange at the placental interface. See, this is fetal stem cell, this is heteroblast. They interact with maternal myometrium and ultimately maternal cells. There is local immune system. There is which is contributed by both fetus and maternal side, and there is local neuroendocrine changes which are again contributed by placenta, mother and possibly fetus, and all of these produce a complicated net which would ultimately give fetus some attribute of mother, mother some attribute of fetus. This is another view. This is endothelial cell and maternal blood cell. And see, this is fetal cell-free DNA, and this is maternal cell and maternal cell-free DNA. All of they exchange together. And this is feto-maternal microtube chimerism. Fetal cell go to all over the body of mother and settle there. Maternal cell go to all over the body of fetus and placenta and settle there. And this cell help in tissue repair of mother during pregnancy. They change immune response in mother during pregnancy and reduce the autoimmune diseases. There is one curious finding that all autoimmune diseases go into remission or mostly remission in pregnancy because the feto-maternal chimerism actually directly contribute to the immune suppression along with the endocannabinoid system and endopioid system of mother. And these are the various diseases that happen due to feto-maternal chimerism. Means at brain, glioblastoma, meningioma, so-called Alzheimer or rather every neurodegenerative disease, they happen due to feto-maternal chimerism. Similarly, SLE and all so-called systemic vasculitis, then various cardiomyopathy, then allergic tendency and various immune system disease, various cancer, and also various autoimmune disease are produced by this feto-maternal chimerism. And you can easily imagine every psychiatric symptom are produced due to a contribution from feto-maternal chimerism. So, standing there, there is no way we cannot continue psychotropics in patients who are pregnant. Same was done in this patient, and this patient was extremely complicated. So, talk with gynecologist was initiated, and it was firmly discussed that she would lose pregnancy if she was not given psychotropics. And we have provided various reading materials and various papers giving strength to our arguments. and then keeping the gynecologist and internist in team, the management protocol initiated. Patient was given escitalopram in gradual titration up to 30 milligram and was given olanzapine 5 milligrams, stopping aripiprazole gradually. She was also given propranolol 60 milligram. Lithium was continued. She was kept in multi follow-up regime along with team management. Means every time 3 of us used to see the patient together. First follow-ups of patient doing better. The third follow-up during second trimester saw relapse of psychosis and olanzapine had to be increased to 10. This actually alerted the internist, and internist started the patient on rivaroxaban 20 during the late second trimester because the coagulation profile actually started destabilizing in late second trimester. Thankfully, there was no preeclampsia or toxemia in this pregnancy. Just there was hypertension, which was managed, and she gave birth finally to a healthy baby at 37 weeks via planned cesarean section. Baby suffered no ill consequences in immediate postnatal life and was breastfed normally. Now the current status. Mother is doing well on escitalopram 30 lithium, 400 milligram SR and cariprazine 1.5 milligram now. 2 years postnatal life, the baby is showing early sign of deviant developmental trajectory. What are these early signs? The baby has nighttime arousal and had not slept at night during first 6 months of life. Then there was difficult feeding. Then there was various GI infection in early infancy. There was also a period of hospitalization due to pneumonitis. At 1.5 years of age, the baby showed allergic asthma, or rather early signs of allergic asthma in form of seasonal exacerbation of bronchospasm, and the treatment was initiated. There is temper tantrum and anger outburst, but this is expected in this baby because as we have not done any genetic test yet, but we can be sure that this child is also carrying the plasminogen activator inhibitor 1 wild mutation of 4G5G. So standing there, this child is very vulnerable to development of psychiatric symptoms in future. So this is very broad overview of today's topic. I hope I have given some understanding of this difficult area. I don't know how far I have been able to show you the complexity, but let's hope we can someday start a series of discussion on this area because this is the future.
Wow. That was really a very interesting talk, and unfortunately we could not make it interactive. But Dr. Bhaskar Mukherjee, I'm sure you've shaken up the people and made them think about, how they view psychiatry first and foremost, and how to really approach cases. Some of the questions, I know that you have said that you're not going to talk about diagnostic disorders and diagnosis diseases, but there are yet some questions which have come up, and I will ask them if you think it's worth answering. So one of the questions is incidence of bipolar BMT in females, and how
Incidence and prevalence are my weak areas. I don't remember. That is actually information that can be found on Google. But again, I am directly saying, don't trust these incidence and prevalences because they are not population level data. They are just a few study data. There is no population level data. Even the previous assumption of 1% prevalence of schizophrenia is being challenged, questioned, and obliterated in 2020 already. So standing there, whatever data you get, question that and have a healthy skepticism about it.
I hope that answers you, Dr. Anju Kumari. And Dr. Tushar Bhatt from Dhule is asking, the postpartum doses are more, is it an exceptional rule or something more? So he wants to know about dosing in postpartum period.
Yes, more postpartum doses normally should be more depending on symptomatology. The ultimate guide is symptomatology. Some brain somehow tolerate the postpartum hormonal crash pretty well. Some brain doesn't. And I have realized after getting tricked multiple times that we cannot predict that. So we say that postpartum doses are more, but ultimately it becomes personalized because I have seen many patients who after delivery of fetus actually needed very less medication. And I have seen many patients who needed more, but at least 90% of them have tricked me and have made me do wrong judgment. Means I thought this patient to have more genetic load, so let's increase the dose, and I found nothing. So was the dose increase aborted the attack, or the dose increase was not needed? I don't know. And many a times I thought that this patient has mild genetic load, mild pregnancy course, so let's reduce the drug. And more often than not, that created a lot of problem. So that is why I say better keep it personalized, but generally keep a higher dose. Now, Dr. Suresh Kumar has asked the choice of different medication in prescribed in this case. Case 1. In case 1, semaglutide would be the most controversial choice. It was given because incretin-mimetics are regularly getting various reviews that they are very good for brain health. They reduce impulsivity, they reduce so-called low mood symptom, they reduce suicidality, and they stabilize the patient. Even if there is no prominent other psychiatric symptoms. Now, this is something very, very interesting. And I personally started noticing that a few years ago when two patients of mine who were supposedly so-called borderline personality was prescribed liraglutide by their endocrinologist. They responded beautifully. I was having difficulty in managing those patients' mood problems and other things. Then liraglutide started and patients become very stable. This started my interest in this incretin-mimetic group, and I have started experimenting on these people. These in patients who can afford them and who have sufficient justification in using them. Means overweight patients or patients who have type 2 diabetes, which is not getting controlled by other medication. And so far I have found very interesting things. These incretin have really good brain effects. So that is why I started semaglutide in that patient. And fortunately, my experimental trial worked. Would other incretin also do the same in this patient? I don't know. In future, the patient has planned to go to Australia, and at that time, I am planning to hand her over to an Australian psychiatrist. Then we might try changing the incretin to other group and something like that. And that would answer this query of mine. I also have this query. For naltrexone, the choice was clear. I already have seen the patient has polycystic ovarian syndrome. I already have seen the patient has impulsive eating. I already have seen that the patient was on valproate and didn't respond. Giving lithium to her and giving other so-called anti-epileptic to her was the one other choice, or I would have to think about something which would change the metabolic syndrome, which would help the food habit, which would help weight loss, and which would work well in sync with bupropion, because she was having attention deficit, so I have to give bupropion. Standing there, naltrexone, which is actually approved treatment in combination with bupropion as weight loss medication, appealed to me. So I started the patient on the naltrexone. She didn't really was well on 50 mg, but I kept the dose up to 100 because her weight was, again, I am saying 120 kg. At 100 mg, she responded beautifully. So this was experimental trials. I am happy that I got good result in this patient, but it might have happened that I would have failed and this patient would have changed to a fourth psychiatrist. So that is the rationale of mine in prescribing this medication. Now Ruksada has asked perimenopausal transition, menopause impact on mood disorder. Excellent, because this is something I could not give as a case, because after writing these two cases, I understood that these two would take at least 1 hour. So I would not be able to add a third and they enlarge that talk to 2 hours. Ruksara would kill me. So I omitted the very important perimenopausal thing. Menopause affects woman's brain extremely hard. Woman's brain are more malleable than male brain. More malleable means more tolerant to chronic stress, more tolerant to chronic daily stress, more tolerant to various immune changes, more tolerant to various environmental insights, because they have two hormones, gonadal hormones, which extremely efficiently manage cerebral neuronal turnover, cerebral immune system, and interaction between neuronal immune system or cerebral immune system and systemic immune system, and also these two hormones causes a lot of resilience to brain. Now, when the ovary stops functioning, this mattress or buttress to brain is lost in case of female, and that gives rise to new onset psychiatric symptom in the form of anxiety, depression, psychosis, and various other things. So peripartum period would see either new psychiatric symptoms, which might be psychosis, which might be depression, which might be so-called mania, which might be so-called obsessive compulsive symptom. Peripartum stage would show various vasomotor symptom in the form of burning sensation and irritability and other thing. Peripartum stage would also show change of pre-existing psychiatric symptom, and ultimately it would complicate whatever psychiatric treatment is going on at this moment. So that is peripartum period, perimenopausal period in a nutshell.
Thank you. I think you really concise that answer, because you told us in the beginning it would take an hour to discuss this topic.
Yes, I was thinking and I was trying to concise it.
Thank you very much, at least for that pearl of wisdom. And this is really the last question, because I know it's time for the next thing. But
I would like to take two more questions. One question is actually one line answer. They imported. They are actually fabulously rich. So they imported semaglutide.
All right.
And the Addison's disease going to remission. Some Addison's disease, if the Addison's disease is due to autoimmune causes. Now, another question was
SSRI induced first trimester abortion.
SSRI induced first trimester abortion so far is not proven. Rather, SSRI many a times prevent first trimester abortions by increasing the efficiency of maternal immune relaxation. So that would be debated, very, very debated. So Dr. Iman, probably that is something we wrongly believe, that SSRI induced first trimester abortion entity probably is not there.
Fantastic. And with this, I really, really need to end this session because we have to give way to the next. Dr. Bhaskar Mukherjee, thank you so very much for your pearls of wisdom. And I really appreciate the case-based learning and trying to link really the basic molecular understanding to psychopathology, and therefore how treatment can be planned. Maybe we'll need many more such sessions before we can start thinking like this and working like this. But it has been an eye-opener for many of us here. And on behalf of the organization and personally on my behalf, I thank you for this wonderful presentation. And I'm sure there are many more questions that will keep coming, and we'll have to keep getting you back to hear more. Thank you very much. And may I hand it over to Hina to continue the next part.
Yes, thank you.
Thank you, Bhaskar. Can someone stop Bhaskar's screen? Thank you, Bhaskar, once again. Thank you for actually coming. You really had me anxious there. Thank you, Heenal ma'am. Thank you once again so much for chairing this session. Bhaskar, there are a couple of questions which have been sent separately to me. If you're okay with it, I can mail them to you. And
yes,
if that's okay, you can get back.
Just send me WhatsApp. I'm more comfortable in WhatsApp.
I will do that. So once again, thank you, Dr. Bhaskar, and thank you, Heenal ma'am, once again. We now go on to our session 2, which is comprising of 2 parts. The first part is a talk on motivational interview in women. And the second part is a clinical presentation of mood disorders in women, which will be presented by our resident medical doctors. For the first part, which is the talk on motivational interview in women, may I call upon our speaker for today, Mrs. Mridula Joshi. Mrs. Mridula Joshi is a counseling psychologist with 8 years of experience in the field of mental health. She's an expert in psychotherapy approaches of REBT and play therapy. Currently, she's associated with Empower, the initiative by the Aditya Birla Education Trust, as a mental health expert. I welcome you, Mridula, and I hand over the session to you. Mridula, are you there?
She's there, but she's not audible.
Hello? Hello, am I audible now?
No, Mridula, you're not audible.
Is it better now?
Yes, much better.
Yeah. Zoom creates problem every time I try to speak anyway. Thank you very much, Dr. Hina, for giving me this opportunity, and good evening, everybody. As Dr. Hina mentioned that I'll be talking on motivational interview in women with mood disorder, and also be sharing my screen quickly before we go ahead. I'll confirm if it's visible to everyone. Is it visible?
Yes.
Slideshow mode. So, as Dr. Hina introduced, I am Mridula Joshi. I'm a counseling psychologist, and I have a special interest in working with children and women. So, before we go ahead with what is motivational interview, let's first try and understand the prevalence of mood disorders in women. The prevalence of mood disorders was reported from the range from 0.8 percentage to 9.6 percentage of the population across the countries, irrespective of the gender. In the WHO-led World Mental Health Survey, in a similar survey, it was found that women are at 50%. Women have 50% high chances of developing mood disorders than men. Research in India specifically suggestive of higher percentage of major depressive disorder than any other mood disorders in India. That's probably because the presentation of mood disorders differs as per the social demographic characteristics. In a research study which I was referring to, a lot of social demographic characteristics were explained, and the research mentioned that women from metropolitan cities, because of the educational background, because of the working background, they are more vocal, more able to identify and label the emotions than women from rural parts of the India. However, the impact remains similar, more or less same, all across the groups. So, be it a women from rural India, be it a women from metropolitan city of India, the impact is more or less the same. There is no statistical significant difference in the prevalence. Now, what is motivational interview? It is a client-centered approach which helps people find motivation to bring positive changes in their behavior. So I am not keeping everything really very theoretically oriented, but I would really want to make it listener friendly so that they adapt to the concepts very quickly and easy to comprehend what is happening. And motivational interview in its way empowers individuals to take responsibility for their own recovery, especially to people who are unsure and have mixed feelings about changing the behavior. So sometimes we will find women coming in with the thought that, should I really change this? Should I really not change this? Will I be accepted in my family, by my partner, by my friends, if I bring this change in my behavior? And motivational interview in its own way empowers these women to take up the responsibility for whatever they have done, so whatever they are experiencing right now and where they want to land, what is their goal, where they see themselves in the specific amount of time. this is a very helpful tool and approach which can help people. So initially, motivational interview was designed was it was found to be very helpful for people with addiction and substance use disorders. But in a recent times, it has shown that motivational interview also has a significant impact for people suffering through mood disorders. And today, because we are talking more of women, now actually women getting help from all kind of mood disorders, be it bipolar disorder, be it unipolar major depressive disorder, be it premenstrual syndrome or premenstrual dysphoric disorders, all kind of women with thyroid disorders do get help from this, and I widely use it.
I'm really sorry to be interrupting in the middle. It's just there's a lot of disturbance and we can hardly hear you.
Mridula,
Yeah.
I have been told by the tech team that if you can try speaking without the headphones, I think the disturbance is probably because of that. So, could you please try doing that?
I'll definitely do that. Also, give me a moment. Maybe I should try and switch off the fan. Is it better now? The disturbance has reduced.
Yeah,
Hello.
it's slightly better. Yeah, definitely better. Yeah.
All right. Thank you. Thank you very much for bringing that in. So when we are talking about key aspects of motivational interview, as you know, classically called the spirit of motivational interview, first important factor is collaboration, where therapists. So I have also given the reference part in the same slides for the viewers to be, it's easy to understand for them. Collaboration. So it uses the aspect that therapist and therapist and client work in a collaboration towards achieving the goal. It's not therapist dictating or confronting, as in some of the classic therapeutic approaches, about how the therapist, how the client's behavior has been and what are the implications of those behavior. But being in a partnership with your client and actually working on the decision making together is what promoted in the motivational interview. And I've seen this a lot of times when the patients will come up with the concerns that, this is what I need to work on, and I had been really struggling with these kind of issues. The minor changes in the therapist's conversation, I know the minor shift from you probably have missed out on that, and shifting it to we have missed out on that, and probably we can work on this. These minor collaborative phrases itself assures the client that we are in this together, and that's what also gives them a lot of sense of empowerment and helps them to be in the process of the therapy. Evocation is where the practitioner activates the patient's own motivation. Basically draws out the reason and draws out actual motivators to bring the change in their behavior. The practitioner connects health behavior change to the things that patient cares about. So what are the most important aspects? What are they looking at by the end of the therapy process? And what will they be achieving? Where will they be exactly? Is what we are talking about in the evocation. On the contrary, when therapists use the educational approach and try to teach them, try to guide them, in order to create the insight and decides tries to bring the client on the pre-decided path. That really may that may put sometimes clients off, because it is not perceived as the collaborative process. But if the therapist evokes the process and what are the how it is going to impact your life, how it is going to help you to achieve your goals, and how we can do that together again, will usually does help clients to stay in the therapy process. Autonomy again helps clients a lot. Therapists who give the space where where they acknowledge that client is the best judge of themselves, and client knows what is the best for them, rather than we being a professional, we being an expert of mental health and telling them that this is what is best for you. Giving that giving that autonomy, giving that comfort zone, and allowing them that space is what motivational interview approach promotes a lot. Moving on to next slide. So this is the change model. This slide and next slide I'm going to really talk about in a manner together, because a lot of the content in these two slides is going to go hand in hand. So these are the change model. Basically talks about 4 changes when the client comes in with a specific issue, what happens exactly. So there is a pre-contemplation state where we review what is happening, what are the challenges the client currently is facing, what are the issues she or he has been going through. But since we are talking about women today, mostly, but this is a general model anyway. So pre-contemplation stage where we just explore about the problem, about the situation, about where we are, what can we do, what are the limitations, is the pre-contemplation. In the contemplation stage, when we are trying to get ready, we weigh up the pros and cons of change with the patient as well, on helping them to balance by exploring ambivalence and alternatives. So what are all the alternatives we are talking about when we try to cope with the problem, or we try to generate solutions for this problem? Identifying reason for change and risks of not changing, disadvantages of not changing is really, really important at this stage. Increasing the patient's confidence in their ability to change again is very important. Preparation and action, so clear goal setting when we are actually into the action mode. Whatever we have discussed so far in last 2 stages, we put them into the action and try and execute it towards adapting the positive behavior, adaptive behavior towards adapting the healthy goals and healthy changes in our lives. Maintenance, once we have achieved it, doesn't mean that we are done with it, but really maintaining it, because at times maintaining at the same stage can be really, really challenging. So sticking to it is a challenge in itself, because sometimes it may take a woman with dysthymia to come to a particular stage and being start being optimally functional in her work, but staying there for maximum duration or as much as she can is also very important. She achieving it for 2 days and then going back to the olden patterns of behavior is not really going to help her to to cope with the problem and problematic situation for long. So maintenance stage is equally important. And preventing relapse. So preventing relapse has a lot of importance when it comes to motivational interview, but it is also considered very natural if the relapse takes place, right? Because we all are human, and we can go back to where we were. We can crash at some times if the situation is really very stressful. We have our own limitations. So learning from relapses. So what motivational interview really focuses on is learning from the relapse, what mistakes actually happened, or where did we leave the loops when we prepared the plan last time, and how can we overcome with those loops this time, is what motivational interview focuses on when we talk about relapse. Strengthening the commitment. So when we talk about pre-contemplation and contemplation stages, the most important aspect comes when in an execution, even in the second stage of contemplation, that why are we doing this? Why is this important for us? Why are these goals important for us? So disadvantages of status quo. So I would often get women in pandemic. I've seen a lot many women coming with not only standalone MDD or dysthymic disorders, but many of them came up with the relationship conflicts, including infidelity issues. And one of the women I clearly remember very clearly said that, why should I change? I am not the one who has cheated in this relationship, but he has done. So why should I change in this therapy process? So let's assume for a moment, if you don't change, remain where we are, right? What happens? What are the difficulties? This really talks about, as I had said, in the no substance or alcohol related issues. But when it comes to mood disorders, it is also important to focus on specific behaviors of an individual and analyzing the disadvantages of status quo, advantages of change. So what happens if you change? If we continue the same example of the women, what will happen if you change in your approaches, in a way you deal with the problem situations? How will it help you as an individual?
So it will affect you less.
Right, isn't it? And that helps you to reach to your optimum levels of functionality, because relationship is one significant part of your life, but there are many other aspects of your life. If you focus only on this, all those other areas also will get affected. You're not only a wife, you're also a mother, you're also an officer, you're also a daughter, you're also a sister. You're more over everything. You are one self, and compromising yourself for one.
Mridula, sorry, we've lost your voice again totally.
Am I audible now?
Uh, Not loudly.
Is this better?
No. Very faint. No.
Hello?
No. It's still faint. Yeah.
Hello?
I mean, the voice is there, but it's just a bit faint.
All right.
If you have another set of earphones, you could try with that.
Hello?
Yeah, this is better.
Okay, so maybe I just plug out and plug in once again. That helps. So when we move ahead and talk about strengthening commitment, do you want to go through the advantages of changes again? Hello?
We can hear you.
Please.
Yeah.
Next, please.
Next. So opposite for change, when we have already achieved something, when we have brought significant changes in our life, and how have they helped us, how have they had a positive impact on our current life, focusing on them and actually taking our clients ahead from building an optimism for the new thing as well, help them a lot. An intention to change, in what ways you want your life to be different in 5 years? I use this time projection technique a lot with many of my women clients who are only thinking about the current issue, what has happened in the past, really not thinking about what is going to happen after 6 months, where they are going to be after 1 year, where do they look at themselves after 5 years. Why am I looking at bringing this change in my life, in my perspective, in my behavior, is what very important. So intention to change, and emphasizing that is also very important from motivational interview point of view. What is the therapist's role and principles of MI, motivational interview? So these are very, very important aspects of motivational interview. And first, being empathy, I cannot not emphasize the importance of it. I don't think it's just a skill. I think it's a value in itself, and each living individual needs to have this, because empathy is what really brings clients on board with you. It not only helps us to establish the rapport with the client, but acknowledging that they are going through is natural, and they are not sole responsible for this situation is very important. Being empathetic in the therapeutic process does not mean that we are agreeing with the client, but we are assuring them that they have the safe space where they are accepted as an individual without being judged.
Mridula, sorry to interrupt, but I think we're overshooting time.
I think these are the last 3 slides I have. I don't have much content.
Because
Okay.
after this, there will also be question and answer sessions, and I can
Right.
already see 1 or 2
Right.
questions in the chat box. So if you could please wind up.
Yeah, sure. Develop discrepancy, showing clients that where they are right now and where they see themselves at goal setting. Having a very clear goal setting is very important to create this great clients and help them stay motivated to reduce the gap and be on track in order to achieve their goals is very important, and that what's actually motivates them where they are and where they see themselves is one of the very important motivational factor. Role with resistance. So when clients are not really very clear that oh, should I bring this change, should I not bring this change, I don't think this is required, again going back to what are the disadvantages, why are we doing this, and where would you land up after the entire process is what going to help them. And supporting self efficacy, especially in women clients, is very important because Indian women, most of them tend to have the self image on the basis of others validation. If my husband approves of me, if my in-laws approves of me, if my parents approve of me, I am the better person, otherwise I am not. So whatever they have achieved, whatever they are capable of, how they have dealt with things in the past, and emphasizing them, supporting them with their capacities will help them to boost their confidence, and that's how they will go ahead and stay motivated to achieve their goals. Benefits of mood disorder: strengthen self-confidence and trust on oneself, which is very, very important when it comes to bringing any kind of a behavioral change. Own up their actions. Whatever I am going through is not really because someone externally or something externally happened to me or someone externally did it to me, but it's because of my own actions and my own choices. Helps to be compliant to the treatment, not only to the therapeutic process, but also to the medicinal treatment is very important, be it any kind of mood disorder, because many of the women I have recently seen will come up with the concern that, I'm not really very comfortable with seeking the psychiatric help because I'm very scared of side effects of the medicines, and helping them, motivating them to take the psychiatric medicines, and how will they help them, now will they not really make them dependent for lifetime, and their positive role in the entire therapeutic process will help them, basically mi will help them to be compliant to the treatment, be it only psychotherapy or combination of psychiatric and psychotherapy. Assures more power and control of their own life situations. So this is where if a woman feels powerful, um, she will definitely take up the responsibility, and motivational interview assures them the power of their situation. Take responsibility for themselves. I think I pretty much covered that in the previous explanation, and prevent relapse, which is very important aspect because change needs to be constant. If we are stuck at one point, they go back, have a same battle all over again, and come back is going to be very exhausting for the client. And that's what we also need to be very, very careful of. So preventing relapse helps, a motivational interview helps a lot to prevent relapses. Limitation um, might not be an ideal approach for all the clients. As we said it, some of the times uh, it has shown standalone results with the addiction related issues, but when we are talking about mood disorders, the evidence based research has said that has have reported that more of a collaborative approach with other schools of thought has shown a significant impact than only standalone motivational interviews. So I even personally a lot many times use it in a collaboration with REBT and CBT, and that shows wonderful results than standalone motivational interview. Works best with individuals who have mixed feelings with regards to change in their behavior. That basically when they are not really very sure if they want to bring this change, as I said in the beginning of the session, that will they be accepted, will they be not, especially being women in Indian society. So this motivational interview will may not be helpful for people who are highly motivated or absolutely not motivated. So people women who are in a confusional state, should I not, should I not, MI is best for them. But women who don't have any motivation, it's very difficult, and who are highly motivated, they do not need anything externally from the therapist. Also, what we need to keep in mind as a professional, that motivational interview approach talks about the behavioral change, but emotions, um, other factors which contribute to the psychological state of an individual, we cannot really overlook them, and that's why collaborative approach is always recommended and suggested. um, that's all from my side. Thank you very much. Do we have any questions, Dr. Hina?
Thank you, Mrs. Mridula Joshi. At this point, we'll continue on with the session, and we will see if we have time for Q&A at the end of the session. Please stay tuned. Dr. Avinash D'Souza, welcome, sir, President of BPS and General Secretary of IAPP. He's going to take over for the next session. Dr. Avinash D'Souza.
Well, good evening, everyone, and it's a pleasure. I will now invite, the session is going to be 3 cases which we're going to run because we lack of time here, and each of these will look at mood component, some morbidities in mood female patients. First presenter is Shahrukh Motwani, who's a resident at the Department of Science Hospital. Shahrukh, please share your screen.
Yes, sir. Thank you, sir. Good evening. I'll be sharing my presentation. All right. My case is as follows. Mrs. XYZ, a 45-year-old female, right-handed, educated till 10th standard, working as a receptionist in a clinic, Hindi-speaking, Hindu, married, resident of ABC, was brought by her husband, who was her objective data, an inadequate and reliable one, with chief complaints of suspiciousness that her neighbors are conspiring against her to kill her, hearing voices of men calling out her name and commanding her to do tasks, wandering behavior, and decreased sleep and appetite. These complaints were present for the past 2 years. In her longitudinal history, around 2 years back, the patient's husband noticed that she had become very irritable, distractible, was muttering and gesticulating for long periods of time. When asked what she was muttering about, she would get irritated and often would lash out at family members, would get angry, abusive, and also assault them. Over the course of 2 years, her self-care also deteriorated. She would not bathe, change her clothes for days. Her sleep time also reduced, and she would stay up late at night, sometimes trying to leave the house. She would often leave the house and would be found in the neighbor's house, fighting with them over and threatening to kill them. She would accuse them of trying to kill her and would believe that her neighbors had plotted against her while she was asleep. This is why she refused to sleep at night. She also claimed that she would become the Indian Prime Minister the following year and that she had immense popularity. She believed that her neighbors were jealous of her success and hence wanted to assassinate her. She would talk continuously about her future plans, which was unlike her usual behavior. She would claim that 3 men in her neighborhood, along with her husband, would occasionally whisper derogatory sexual remarks in her ears. She would also sometimes tell her, they would also sometimes tell her to sit at one place, to move out of the house and go somewhere, and would accuse her of being a bad wife and bad mother. Over the course of 1 year, she also started suspecting that her family members are speaking ill against her whenever they would talk to each other, especially behind her back. This resulted in her getting preoccupied, where she would listen to their conversations to the point that she stopped doing any of her household chores. She also stopped caring for her child and stopped eating adequate amounts of food or feeding her child, which is why it was decided to first take her to a faith healer for around 2 months. After noticing minimal improvement in her condition, she was finally brought to a psychiatrist. There's also a history of cannabis use in while she was in school. It was usually with her friends in junior college. However, after smoking cannabis daily for about 1 year, the patient started developing suspiciousness over her friends that they're conspiring against her and trying to poison her food. She would occasionally get aggressive with them, so her friends stopped hanging out with her and her cannabis consumption reduced. Her last consumption was 2 years back before she got married. There is otherwise no history of any other substance use, no history of any pervasive sadness of mood, No history of suicidal ideations or attempts or anxiety features. There's also no history suggestive of obsessive compulsive features, personality disorder, or other intense specific fears. In her pre-morbid personality, according to the patient's mother, she was a very cheerful person but stubborn in nature. She used to like things done her way, which would quite often lead to conflicts with peers and siblings. In her schooling history, there's a history of bullying in school, particularly for her short stature. So for the duration of her school period, she remained quite dull and did not make any friends. This changed in high school when she started getting assertive and eventually stubborn. She also started lying and stealing while in high school and was caught a few times by her teachers stealing school supplies. This led to her getting suspended from school twice. She had also driven her friends' motor vehicles a few times while being underage and was caught by her father. Due to the bullying in school and her lack of interest in studying, she also faced academic difficulties and struggled to pass in every grade. In her past medical and surgical history, she has a history of hypothyroidism since 4 years and is currently on treatment, however, with irregular compliance. Her menstrual history was as follows. She attained menarche when she was 14 years old, that is around 11 years back. Her menses are regular and with adequate flow. Her last menstrual period was 10 days back. The patient was adopted by her adoptive parents when she was 3 years old after her biological parents died from a road traffic accident. She has one younger stepsister who is currently taking care of her child. She lives in a rented house with her husband and 1-year-old boy child. In her general examination, the patient was average build, unkempt, undernourished, and was seen to be muttering to self. There were no signs of cyanosis, clubbing, edema, icterus, pallor, or lymphadenopathy. Her blood pressure was 120 by 70 millimeters of mercury, and her pulse was 78 beats per minute. Her respiratory rate was 18 per minute. On systemic examination, no abnormality was noticed. On her mental status examination, the patient was conscious, minimally cooperative, not responding to questions regarding orientation. Eye-to-eye contact was initiated but not maintained. Attention was arousable but ill-sustained. Rapport was not established. Mood was not conveyed, but her affect seemed irritable. Her speech was with reduced output, and it was repetitive and occasionally irrelevant. Thought could not be demonstrated, and further mental status examination was deferred as the patient was uncooperative. She was given a diagnosis of schizoaffective disorder, and the patient was started on the following medications after she showed improvement in her condition. Tablet olanzapine was given, which was 10 milligrams. Tablet haloperidol was 5 milligrams. Tablet trihexyphenidyl was 2 milligrams, and tablet lithium was 400 milligrams. Injection haloperidol 5 milligrams along with injection phenargin was kept 50 milligrams intramuscularly on an SOS basis in case the patient got aggressive. Her family members were also psychoeducated about the biopsychosocial model of the disease, and the risk of future cannabis consumption was explained. That's all. Thank you.
Well, thank you for that presentation. The points which, the reason we've chosen these cases for us is because what we refer to as complex kind of cases that practice. To a lady who primarily was presented with symptoms, but she also had an episode probable medication, past history of abuse and cannabis continued probably a year back. She was adopted. Don't know about the genetic treatment, which was here. We also had a history in academic difficulty. There was a developmental tree that probably pushed and propelled towards a mood spectrum. We throw in fact the presence of hypo, and we all know that hypo symptoms can be to both this as well as mood. And so basically is a question to explain that we make the symptoms of feelings, particularly primarily psychotic or also have cannabis courses or primarily have a schizophrenia-like picture, but initially with moods, which then results in the development of psychosis. We're not here to debate choice of antipsychotic, choice of mood stabilizer. I think as clinicians will have our choices, prescription would vouch for. What's very important is the fact that some you may used to have to use referred to as conscious rational pharmacy in cases where you combine an antipsychotic, you may have to combine stabilizer, you may have something for sleep, the aggression, all work together for the of the patient. Thank you. I now move to next presenter. Presenter is Dr. Saili, who is a resident of psychiatry science. Saili, please, your case.
Yes, I'll share my screen. Good evening, everybody. I will be sharing my presentation on the screen right now.
Saili's video is working, so please excuse me, but she is definitely presenting. Yes.
Sorry, sir.
Your video isn't working. Absolutely fine, but you can present. Yeah, no problem.
Okay.
Audio is working fine. Okay,
sure. Great. Yeah. So I present my case now. A 25-year-old married female, right-handed, 12th standard educated, homemaker, Hindi-speaking, resident of Dadar, was brought to the OPD by her husband, who was her informant, with the complaints of sadness of mood, decreased interest in previously pleasurable activities, decreased interaction with family members, irritability, passive death wishes and tendency to commit self-harm, and sleep and appetite disturbances, which had increased over the past 1 month. The above-mentioned symptoms had started after an altercation with her mother-in-law. Patient would be sad through the day for most days. She would not enjoy working or helping out at home or watching TV shows or going out for walks, which she would enjoy previously. She would interact very little with her husband, friends, and family members and would prefer to spend time alone. She would get irritated on minimal provocation and would lash out at her family members and would ask them to leave her alone. She would cut her wrists and threaten to run away from home and consume phenyl in fits of rage. She would speak about how the world would be a better place without her in it and would often talk about dying and about the afterlife. She would only sleep for about 3-4 hours every night and would eat very little. In the past, there were history of depressive features a few days after the birth of her child. There were crying spells, sadness of mood. She would not pay attention to the child. She would stay lost and she would not take care of herself or the child. She would not sleep well as well. Medications were started for the same. However, the details of the same were not reported by the patient. They were discontinued by the patient after a span of a month. No complaints were reported since till the current episode. There were history of multiple instances of self-harm in the past in the form of wrist slashing, which were usually following altercations with her family members or friends. There were no history of admissions or any treatment which was sought for the same. There was no history of hearing of voices, suspiciousness, fearfulness, no history of over-talkativeness, overspending, hyper-religiosity, or over-grooming, no history of palpitations, restlessness, or feeling of impending doom. There was no history of any obsessions, compulsions, or intense specific fears. There was no history of any substance consumption, no history of head injury, seizures, or any other major medical or surgical illnesses. In family history, there was history of alcohol abuse in her father. Let's take a look at her personal history. Patient was a full-term normal vaginal delivery, had cried immediately after birth. Her birth and her developmental milestones were within normal limits. Patient was educated up to 12th standard, after which she did not pursue further education due to lack of interest. She was average in her studies. Features suggestive of hyperactivity in childhood were present as per her husband and the history that she could give. However, no treatment was sought for the same. Patient is a homemaker. In her social history, she is the youngest of 3 siblings. Her mother works as a house help. Her father passed away 5 years ago due to complications related to alcohol abuse. Currently, patient is living with her husband, son, and in-laws. Relationship between her and her in-laws is cordial, with frequent conflicts between her and especially her mother-in-law. Husband is the only earning member of the family, and the social support is poor. In menstrual history, she had gotten her menses 20 days ago, and her cycles are fairly regular. Pre-morbidly, as per whatever the husband could describe, he described her as impulsive and quick-tempered. In general examination, patient was thin-built, averagely nourished. Her pulse, respiratory rate, and blood pressure were all within normal limits, and there was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema seen. Her systemic examination was also fairly within normal limits. On mental status examination, patient was conscious, cooperative, communicative, well-groomed, and interested in the interview. Her eye-to-eye contact was initiated and maintained. Her attention, active and passive attention, were both within normal limits, and rapport was established. She conveyed her mood as sad, and she had, in thought, she had given ideas of hopelessness, helplessness, and worthlessness. Otherwise, the mental status examination was fairly within normal limits. A diagnosis of major depressive disorder with cluster B traits was made on the information that was given. Investigations done were within normal limits. Patient had improved on 20 milligrams of escitalopram, which was given on an outpatient basis. The patient and family members were educated on the nature of the illness and the need for compliance in medications, as the patient had earlier also suffered from a depressive episode and the medications were not continued.
Well, Saili, for that question, this second case where we're looking primarily the assessment of where we have someone with a depressive disorder, where there can be a postpartum observation of the development of depression. So happen that there is a past history of major depression, and we see the accent of postpartum depression in this. What's very in this case is that we have a girl who's 25, and the presence of traits or personality traits.
Avinash, your voice is breaking. You want to
Trying
check
what I can't.
earphones,
Wait,
please?
Is this better?
Yeah.
Yeah. Okay.
Yeah, it's much better now. Yeah.
Yeah. So we now here have a case where we have a patient with mood disorders, where we primarily have a case of major depression. A case of major depression that has depressive features that could result in the accentuation of postpartum depression. And postpartum depression also presenting in the same patient. But what's more interesting is the presence of cluster B features and borderline personality traits in this patient with a history of self-injurious behavior. Now, a very important factor here is that the patient responded to a single drug like escitalopram 20 mg, which is very common in our practice. But what's very interesting here, I think the choice of antidepressant is something that could be debated. There would be a group of clinicians who feel that she may have done better on an SNRI. There may be a group of clinicians who feel she may have probably done better on probably a mood stabilizer SSRI combination, or an SSRI low-dose antipsychotic combination, or an SSRI aripiprazole combination. But I think what's very important here is that more than looking at the whole picture of what psychopharmacological combinations work, we are more keen to understand how mood disorders evolve at different life epochs in a female patient. So someone who presents with a depression at an early age could present with a postpartum depression after the birth of a child, because the trigger of a depressive episode is already there. And the same patient could later present with postmenopausal depression, which we don't know. And when we longitudinally follow up this case, we'll probably have a look there. I now would like to move to my third presenter, Dr. Madhura Godbole.
Avinash, can I interject here?
Yeah, yes, sir. Please.
I'm sorry, everybody. But just the fact that, the first episode that I could gather, that she had a minor, probably a dysthymic depressive episode, for which they took treatment only for a few days, weeks probably, and she returned to premorbid personality and has been stable all through this period without any medication. Right? It also reflects in this case the natural history of depression. Not all depressive patients require to be treated lifelong with an antidepressant or continued on antidepressant therapy. Once they return to personality, they are able to manage well till another stressful, a psychosocial stressor or endocrine like pregnancy or a delivery outcome. Yeah, thanks. That is all that I would say.
Right. Thank you. I now move to our third presenter, that is Dr. Madhura Godbole, who's a junior resident at Nair Hospital. Madhura, please, I've been informed that your video may not work. So you can please go ahead and present. Yes.
Am I audible?
Yep. Yes.
Yeah. Sorry, because of some technical issue, my video is not working. I'm Dr. Madhura Godbole, JR2 from Department of Psychiatry, BYL Nair Hospital. I will begin now. 25-year-old female, Miss X, resident of Mumbai, Bachelor of Mass Media, working in a private company, single, came alone with complaints of sexual response elicited by certain sounds since the last 8 to 10 years, repeated thoughts about genitals of gods or goddesses since the last 2 to 3 years, repeated fear that she might harm her parents since the last 2 to 3 years, low mood since the last 2 years. Total duration of illness being 10 years and course progressive. 8 to 10 years back, patient started to experience sexual arousal, that is sexual excitement with stimulating sensation in vagina when she heard sound of her sister's breathing while sleeping next to her. She experienced the same whenever her sister made sound to call a puppy. Over time, this further extended to chewing sounds made while eating by her sister, father, and younger brother. Also experienced sexual arousal with sound of tap water whenever her father washed utensils. This led to significant distress, and she frequently had anger outbursts towards her family members. She insisted her family members to not make chewing sounds while eating as she gets distressed, but never cited the reason for the same. As the problem continued, she started to avoid family dinners and would use earphones while sleeping or ask her sister to sleep in a different room. On further inquiry on what she did to relieve the distress, she reported she felt relieved only after she masturbated. She had to masturbate 3 to 4 times per day. This made her feel disgusted about herself, but she managed to carry out her day-to-day activities. This continued for about 5 years. Since the last 2 to 3 years, this experience extended in response to chewing sounds of her office colleagues. She also started to have fear that she might focus on genitals of male colleagues. She would constantly be focused in making efforts to not let her eyesight fall over the private parts of males. Because of this, she could not function well while working with male colleagues in the office and also isolated herself during lunch breaks. She felt low most of the times and felt helpless as she could not understand why was this happening to her. Since last 2 to 3 years, she would get repeated thoughts of gods and goddesses whenever she would offer prayers to idols. These thoughts were her own thoughts, but could not control it. She felt disgusted about self and she would constantly apologize to God and later stop praying to avoid the distress. She would have repeated fear of losing her virginity and would be preoccupied to protect her virginity. With this fear, she stopped traveling by a taxi. She would have repeated fear that she might harm her parents, for example, thoughts of stabbing her mother. She started to excessively care for her parents. If things were not placed in a certain order, she would get thoughts that something ill might happen to her parents. She had to check 2 to 3 times if her pants were zipped every time she was back from the washroom. She would also check multiple times if she had switched off the stove. She searched online about her complaints and found that it is a psychiatric illness and decided to seek help without letting her family members know. There is no history of disturbed sleep or appetite, no history of suicidal ideations, no history of hearing of voices inaudible to others, no history of recent fever, head injury, seizure, or any substance use. Past history of hypothyroidism and is currently on medications. There's no history of abnormal involuntary movements or any other medical or surgical illness. There is history of psychotic features in mother with history of hospital admission and ECTs, history of psychotic feature in elder brother, but never treated. There's history of diabetes mellitus and hypertension in father. In younger sister, there is history of deliberate self-harm in the form of slashing of wrist following breakup in relationship. Personal history, birth and development was within normal limits. She was average in studies, completed her Bachelor of Mass Media. Occupational, there was history of frequent change of job. Menstrual history was regular and she was never sexually active. Premorbid temperament, she described self as talkative, took responsibility, made decisions for self, predominant mood being cheerful. Hobbies would be clicking photos, videos of self to get famous on social media, and need for symmetry and orderliness. On mental status examination, conscious, cooperative, communicative, young female, well kempt, wearing jeans and a top with tidy hair, with normal psychomotor activity, attention aroused and sustained, with eye to eye contact initiated and maintained, rapport established, mood been anxious, affect distressed, mood congruent with normal range reactivity, intensity appropriate to the situation, speech was continuous, coherent with normal rate volume, no abnormality of form stream, in possession, obsessions were present, sexual obsessions, fear that she might act on unwanted impulses, example stabbing her mother, focusing on genitals of male colleagues, and blasphemous obsessions. In content, ideas of guilt and ideas of helplessness were present with magical thinking. For example, something ill might happen if things are not placed in a certain order. Concepts, both simple and abstract, were intact, denied any perceptual abnormality, was oriented to time, place, person, intelligence was average, memory, judgment been intact, with an insight of 5 by 6. Diagnostic formulation: 25-year-old female, Bachelor of Mass Media, with history of hypothyroidism, with family history of psychotic features in mother and brother, presented with complaints of sexual arousal in response to triggers, for example, breathing and chewing sounds, leading to significant distress and compulsive masturbation in order to feel relieved since the last 8 to 10 years, with history of avoidance of situations leading to triggers, with history of obsessions in the form of blasphemy, fear of harming parents, fear of losing virginity, and checking compulsions since the last 2 to 3 years. Above symptoms causing significant distress, socio-occupational impairment, and not attributable to any other medical illness or substance use. PMP being extroverted with need for orderliness and symmetry. On MSc, mood being anxious, affect distress. With obsessions, magical thinking, ideas of guilt and helplessness. Insight being 5 on 6. The clinical diagnosis was misophonia with comorbid obsessive compulsive disorder with good insight. She was started on tablet escitalopram 10 mg and it was optimized to 20 mg on further follow-ups. She was also psychoeducated and told to gradually expose herself to the trigger sounds instead of avoidance, starting from the least distressing trigger to the most distressing trigger, with lifestyle modification in the form of exercise. Her YBOX score on the first visit was 28 and current score is 9. Clinically, she reports 70 to 80% overall improvement, and patient currently has dinner with her family members. She started to travel by taxi alone, and there is also improved functioning at her workplace. Coming to discussion, so misophonia is still not defined enough to include in any of the diagnostic classifications. There have been some criteria proposed by researchers like Schroeder and Dozier. I'll just highlight the things which were present in this particular case. Presence or anticipation of specific sensory experience, such as sound, sight, or other stimulus. In this case, it was eating sounds, breathing sounds, which leads to an impulsive, aversive, physical, and emotional response, leading to disgust and quickly becoming anger. The stimulus elicits immediate physical reflex response. In this case, it was sexual response. With potentially aggressive outbursts, the patient understands that the negative emotional experience was excessive, unreasonable, and disproportionate. They try to avoid the misophonic situation. For example, here the patient avoided family dinners and did not let her sister sleep next to her. And this leads to significant socio-occupational impairment. The prevalence of this condition reported is 20% and 60%, but there are more studies required on this as these were mainly done in students of universities. So sampling on a variety of population is required. Misophonia and its association with comorbid disorders. So it is found to be associated with obsessive compulsive personality disorders, mood disorders, Tourette's, ADHD, trichotillomania, and OCD. But there are also reports who say that it is rather a unique set of symptoms and could be an independent psychiatric diagnosis. neural correlates. So it is found that there is decreased mean peak amplitude of auditory N1 component, which is also seen with other psychiatric illnesses like schizophrenia, which can point towards the common pathophysiology. On neuroimaging, on fMRI, there is found bilateral activation in the anterior insular cortex and increased functional connectivity between the anterior insular cortex, which is part of the limbic system, and regions of the brain which are associated with processing of emotions. Other mechanisms of associative learning and non-associative learning are also proposed, and these form the basis for various therapies. No treatment has been scientifically validated, but it is proposed to treat the comorbidities using pharmacotherapy. In our case, escitalopram worked on her OC features as well as it had reduced her sexual arousal. Other psychotherapies proposed are cognitive behavioral therapy, tinnitus retraining therapy, counter conditioning, and mindfulness and acceptance based approach. So these are basically based on classical conditioning and converting sensitization to habituation, which are types of non-associative learnings. The conclusion in this case, symptoms of misophonia were present for 8 to 10 years and symptoms of OCD for the last 2 to 3 years. The immediate physical reflex response was the sexual response. Because of the stigma associated with sexual complaints, especially with regards to women, there was delay in seeking treatment, leading to poor quality of life. So we as clinicians should actively inquire regarding sexual complaints, especially in female patients. These are some of the references and articles. And there is an association called Misophonia Association. They also have a website, and there are latest research articles and all the information on that website. So I end here. Thank you.
Thank you, Madhura. Now, before I just give a few points here, it will be very important for me to state that a lot of people may assume, why we're presenting a case of misophonia or OCD in a seminar that is on mood disorders. There are 5 reasons for that. The first reason being that as a comorbidity may be seen in a large number of patients, male or female. Also, the choice of medication for OCD as well as MDD often is the SSRI group of antidepressants. What's very important here is misophonia is a rare condition. So we thought it does warrant presentation. It's not so common in clinical practice. But for the first time, as you can see, we're using a drug like escitalopram and we're using an SSRI. But we are very okay with the sexual side effects of it, wherein the sexual arousal, is reduced, which is would always otherwise be a cause of concern when we use it in a patient with MDD. So we wanted to highlight that aspect. And most importantly, people would also say we could have used fluoxetine, but yes, the patient did respond to escitalopram. And I think in many cases of misophonia, there's a definite mood disorder component because of the sad sexual stigmatic aspect of the illness that always comes in. So thank you, Madhura, for that presentation. We are running way past our time, so we don't really have time for questions. Someone did mention in the first case whether why we couldn't have started the patient on clozapine. Well, I think we would want to, probably first look at 2 antipsychotics being given, see whether they work well, and then look at clozapine rather than looking at clozapine as a first-line drug. But nevertheless, yes, each clinician would have his own way of looking at cases. Before we end this session and go to the next session, there are just a few things that I want to state. The whole emphasis of these 3 cases were primarily to look at the clinical dimension, the mental status dimension, and the clinical presentation, rather than the psychopharmacological management. And the conundrum of the psychosis, OCD, bipolar, mood disorder association that very often occurs together in most patients that we see in clinical practice were clear boxes of DSM-5 criteria. And now I think today with the release of DSM-5 TR criteria, which will probably not be ever met in clinical practice. Before I go, of course, I may not be there towards the end of this function. Dr. Mittal will, of course, be there. But on behalf of the Indian Association of Private Psychiatry and the Bombay Psychiatric Society, I thank Dr. Rukshida, who heads, of course, the Indian Association of Private Psychiatry Women's Mental Health Committee for putting this seminar together. But most importantly, I want to thank Dr. Hina Merchant, who is neither a part of our Bombay Psychiatric EC, neither a part of the IAPP Women's Committee, but yet totally on my requesting her has gone all out her way to do everything for this seminar. In fact, she's been pestering me with phone calls and multiple things throughout the day to get this seminar going. So we appreciate on behalf of both the associations your efforts to put this together. Thank you. I hand it over now to you and to the next session.
Thank you, Avinash. Once again, I'd like to thank all the resident doctors for this excellent case presentation. We now move on to the last session of the day, which is the masterclass on management of mood disorders in women. And for that, I invite our two chairpersons, that is Dr. Anukan Mittal and Dr. Shashi Rai. Dr. Anukan Mittal, well, sir has done his MBBS and MD psychiatry from Sir Grand Medical College and Sir JJ Group of Hospitals. He has worked in the United Kingdom in the NHS for 4 years and worked at the Regional Mental Health Hospital at Thane for 2 years. His current positions are those of, he is currently the professor and the head of the Department of Psychiatry at Rajiv Gandhi Medical College, Kalwa, Thane, and is the president of the Indian Association of the Private Psychiatry. He is the UNESCO Unit Head, Western India. He is the UNESCO Bioethics Asia Pacific Head. He is also associated with the United Nations Coordinator with the Critical Incident Stress Management Unit, Asia Pacific. He has been the founder president of the Indian Association of Biological Psychiatry, and he's a visiting professor at the Biomedical Ethics SRM University at Chennai and has numerous publications in index and peer-reviewed journals. I welcome you, Dr. Mittal. Our second person, a chairperson for today is Dr. Shashi Rai. Madam has done her MBBS and MD psychiatry from Lady Harding Medical College, New Delhi. She is in private practice since 1996 and is currently the director of Sambal, a drug de-addiction and psychiatric hospital at Lucknow. Her current positions include Chairman of the Richmond Fellowship Society, Secretary of the Richmond Fellowship Society, Lucknow branch. She is a NAP member of the IAPP, Chairperson of the Women Mental Health Committee at the IAPP, Advisor to the IPS Subspecialty Section on Community Psychiatry, Member State of the Mental Health Authority Board in Uttar Pradesh, and the member of the District Mental Health Review Board at Lucknow. She has received numerous awards and was honored by the Minister of Health and Rural Development, Uttar Pradesh, on Doctor's Day. Her past positions include that of being the former president and secretary of the IAPP, UP, editor of the IAPP, and former president, secretary, and editor of the Central Zone and convener of the Special Section on Women Mental Health in IPS. I welcome you, Dr. Shashi Rai. I request Dr. Mittal to kindly take over the session.
Right. I am very thankful to you, Hina Merchant. As Avinash said, you have worked very hard to put together such a complicated program with so many speakers and so many faculty. And I don't know, I still don't have an idea of how many people are actually logged in. And having put together a scientific program which is stimulating in many ways, different topics than the usual. And of course, very experts, people who are well versed and well practiced in the topics that we spoke on. I will take with Dr. Rai's permission, Dr. Shashi Rai's permission, as we discussed. I will take the lead by introducing the speaker. Is that okay? Huh? I can't hear you. You're muted.
Introduce the topic.
Okay.
Yeah.
Okay. Okay. I'll introduce the topic. Right. Okay. 1 minute. Right. So the theme of the program is mood disorders in women across lifespan. And basically, yes, in a paternalistic society like ours, where from childhood, a female child is taught to be submissive, be biased against, to be preferred, not preferred over or preferred equally as the male counterpart of a sibling. And this goes on in terms of responsibilities throughout her teenage, her adolescence, uh, her menstrual cycle, menarche, the whole period of ostracization during the menstrual period, uh, education preferences, financial preferences, being given away in marriage, made to do certain role specific, gender specific roles are assigned, and these kind of stressors are there which persist, which cause a lot of stress. And as I mentioned right at the beginning, uh, I was taught that Indian woman seeks help only when she really, really, really cannot. And we are talking about women in a lifespan. So, as I said, we start from childhood and go up to menopause and to the geriatric age when they get abandoned or they get sidelined if they're left alone. So, today, I believe that we have a very, very senior ma'am with us to talk. And I'm sure Dr. Shashi Rai would have the pleasure of introducing our speaker, uh, discussant, and the moderator. Dr. Savita Malhotra, Dr. Srilakshmi Pingali, and of course, the most active Dr. Shweta Reddy. Dr. Shashi Rai, please take over.
Thank you, sir. And I thank the organizers for giving me a chance to be part of this program, which has been very enlightening throughout the since the evening. We have been learned a lot. And towards the fag end, now we have the master class on management of mood disorders in women. And the speaker is none other than a master teacher. And it will be, all of us are very aware of Dr. Savita Malhotra. Everybody knows her. But still, it will be a privilege to introduce her. Madam, she is the renowned psychiatrist practicing at Fortis Hospital, Mohali. She is retired as Dean and Professor and HOD Department of Psychiatry, PGI Chandigarh, after 42 years of service. Many of you in the audience may not be of 42 years of age, and she has done 42 years of service in one institute. She is well known nationally and internationally for her academic excellence in childhood and adolescent psychiatry. She has numerous books and articles to her credit. So, ma'am would be the speaker, and she'll not be present in live, but her video will be played. The discussant for the day is Dr. Sri Lakshmi Pingali. As soon as I read her CV, I developed an affinity because she's from my alma mater. She's also from Lady Harding. She has done her MD from Lady Harding Medical College, Delhi. Currently, she is the professor of Government Medical College, Sangareddy, Telangana, senior psychiatrist, Roshni Counseling Center and Roshni Child Guidance Clinic. She has been the president of Hyderabad Psychiatric Society, editor Telangana Journal of Psychiatry, and she has areas of special interest are child psychiatry, public health awareness, and licensed psychiatry. So I welcome her also. And the moderator for the session is Dr. Shweta Reddy, a dear friend and a very nice person. She is a consultant psychiatrist at Asha Hospital, Hyderabad, the consultant psychiatrist at Women's Wellness Clinic, Hyderabad. Currently, she is the convener of Women Mental Health and Subspecialty section of IAPP, and her areas of interest are parental mental health, mood disorders, and OCD. So now we welcome all the three wonderful ladies and welcome Madam Savita Malhotra for her talk.
Good evening, friends. It's my great pleasure
Dr.
to
Hina?
be with you all today evening at this
Can the admin
CME
please
of
play the video,
organized by
please?
IAPP and
Can I
Bombay Psychiatric
request
Society.
Yogesh and the technical
My
team
great
to
thanks to
show the
Dr.
video of
Ruksheda,
Dr.
Dr.
Sunita
Hina.
Malhotra?
Yes, ma'am, they're doing.
So basically a master class on management of mood disorders from a master teacher and a very important topic. So I'm sure all of us are hungry for dinner now. It's time, but still we'll have food for our thoughts. Dr. Rukshida and Dr. Hina, to your credit, there are 360 delegates. So that is great.
Thank you, ma'am.
Good achievement.
It's a team effort.
And also the office bearers, Dr.
Hi, it's the recording.
Okay, sure. Dr. Shweta, till the time the tech team can make the video again, if you could, Dr. Sri Lakshmi, we go with the session and do a little bit of a Q&A, and we'll play you at the end.
Sure, no problem.
Thank you.
Good evening, all. I know it is a time for your dinner, but yes, sorry for keeping you late. It is such an honor to be part of the CME, and thank you, Rukshida ma'am, for having me here and having faith in me that I would do some justice to this. So, to introduce the topic as such, diagnosing and treatment of mood disorders in women present its own unique challenges. And firstly, there is data regarding concerning the hormonal effects on moods in women, and also the potential teratogenic effects of these medications, which may impact their use in pregnancy and lactation. And finally, we have certain diagnostic syndromes that are particularly very relevant to women, like PMDD and postpartum depression, postpartum psychosis, and perimenopausal depression. We have with us Dr. Sri Lakshmi Pingali ma'am with us, whom I would definitely bother her with a few questions, which are very tricky, of course. So, ma'am, are you here with me?
Yes, I'm there.
Yeah, thank you, ma'am. Thank you for being here with us. Good evening, ma'am.
Good evening.
So, here I would like to ask you a few questions mostly related to the mood disorders in the treatment of mood disorders in women of all ages. So, starting with PMDD. So here it is one of the most common mood disorder, very prevalent in women of childbearing age. Almost like 50% of women do present with PMS symptoms, and 1 in 20 people have severe PMDD. So we would like to know how its management is different from MDD and what are the different treatment options available, including your serotonergic antidepressant medications and several other OC pills with ethinyl estradiol and dosiperinone combinations. So we would like you to enlighten us with what to use when in this particular population.
Thank you. Thank you for the question, Dr. Shweta. Though I was hoping to start after Savita Madam so that our task will become much easier.
Yes.
But thank you, chairpersons. Thank you, Dr. Rukshida, for including me. Dr. Bhaskar Mukherjee showed us utopia. I will tell you the life of an ordinary psychiatrist. So, and being a lady psychiatrist, pregnancy, lactation, perimenopause, PMS are things that we cannot avoid. I'm sure it comes to gentlemen too, but for us, I think we see it, a skewed percentage of them. So let's start with, like you rightly said, let's start with the beginning of the cycle, that is the premenstrual symptoms and premenstrual dysphoric disorder. So premenstrual symptoms can be a lot of symptoms like the heaviness of the breasts, or the feeling of tenderness, or feeling of or water retention, or lack of energy, or lack of concentration. Premenstrual dysphoric disorder, though, changes when this becomes more of affective features are involved in it, especially irritability and also say anxiety and a lot of anger. And many men, I'm sure, will identify this in their wives and say that, oh, Samay aa raha hai abhi and she's going to be like this. My son and husband gave me a wide berth when I'm in that state. So it usually starts 1 week prior to the cycle. And this is how it differs from an MDD, which persists throughout the cycle no matter what. But PMDD will start at about a week before the cycle, peaks mostly on the day of the cycle, and then goes off within the next few days. That is how it differs. However, many of these PMDDs are known to occur on a background of depression. So when you're looking at an exacerbation, you have to be very careful on, am I looking at PMDD, or am I looking at an exacerbation of, say, a bipolar depression? Am I looking at an exacerbation of the underlying depression, the major depressive disorder, or other things? This is also the time when the migraine worsens with its associated mood symptoms, where the panic attacks can worsen. So differential diagnosis is very important. And according to the DSM-5, when you filter out all this, the prevalence comes down to about 2 to 5% of PMDD. So PMS is very common. PMDD is just about 2 to 5%. Let's make it equivalent to, say, postpartum blues and postpartum depression. Similarly, PMS and PMDD is something we can remember. Why does it occur? Now, I think we have over the years, we've learned that the sudden fall in the estrogen and progesterone just prior to the cycle is what causes this. But the latest literature is showing that it is a sudden surge of in the post-ovulatory phase of the progesterone, of the allopregnanolone, which is the metabolite of progesterone, and its effect on the GABA receptor, which causes symptoms. Now, in an ideal world, when you do not have a propensity for PMDD, the allopregnanolone, or for brevity's sake, let's call it allo, which will act on the GABA receptor as an allosteric modification. And we do know that GABA is an inhibitory receptor and will therefore be anxiolytic. But when the sensitivity of this GABA receptor reduces to the allopregnanolone is when these ladies are supposed to be more prone to PMDD. Also, the fall of the estrogen levels further down the cycle just before the menses occur also is therefore brings about PMDD, is what is hypothesized. It is heritable, where PMS is about almost 80% heritable. So if your mother's suffering from it, surely you would do too. Now, once we come to this, how do we treat it then? Now we know that SSRIs are used in depression. So possibly in PMDD also we will be using an SSRI. The thing here is, since it's confined only to the luteal cycle, can we give the drug just in the luteal cycle and be done with it? It looks like it works. So the first line treatment for PMDD are two things. One is an SSRI, and another is the OCP with the combination of estradiol and droseparenone. So what does the droseparenone do? It keeps the estrogen levels constant, and it also, and estrogen and this droseparenone is also counters the effect of the water retention activity of the estrogen. So they seem to help. Also, SSRIs can be used throughout the cycle, especially if you have a mood disorder, or they can be just used in the luteal phase. Now the question comes, we tell our patients that SSRIs take about 4 to 6 weeks for onset of action. So how can we just give it in the luteal phase and then stop it? It is because it enhances the metabolism of progesterone to allopregnanolone, thereby the disbalance between the allopregnanolone and the GABA receptor that I was talking about sort of normalizes, and therefore you can give. So when you do give an SSRI only in the luteal phase, it works, but you should also be aware that it works more on the affective symptoms like irritability. But if you're looking at somatic symptoms and we're looking at improvement in, say, the low mood, you may have to give round the cycle. So this is in a nutshell about PMDD.
And how about the GnRH agonists, leuprolide and goserelin, and also the pulsatile progesterone that is available? Any insights on them, ma'am?
They are also found to be, but then they are not approved as first line treatment. So these will be possibly as a second line. Also, pulsatile progesterone, paradoxically, sometimes induces when worsens the symptoms also. And especially if you give only progesterone using OCPs, they tend to worsen the mood state. So that should be so. The current literature is only about SSRIs and the combination of estradiol and the drospirenone.
Right, ma'am. So going to the next is, I have a case summary. Mrs. X, who is 25-year-old lady who was on lithium since her adolescence. And she once tried to taper and stop, but suffered from a severe relapse. She is then stable on lithium since the last 5 years. After the relapse, she decided to be on lithium. And now she's married and the couple is now planning for pregnancy. So what is your advice and how do we plan, especially if she prefers to breastfeed her child in the postpartum? And she also has a family history of her mother and sister having postpartum cycles. And considering this, I would also ask you, ma'am, that BD has its onset in mid-teens. And what should be our choice of medications in terms of acute and long-term management, keeping that in mind that one day this girl would conceive and have a child and she wishes to breastfeed her child. So basically challenges to face with the long-term prophylaxis.
Yes. So let's just go back to what Dr. Bhaskar Mukherjee has told us in the beginning. I will not be able to tell you at his level, but at my level, before we talk about drugs affecting the pregnancy or drugs affecting the development of the baby, let's also look at the various risk factors that come along with, say, a bipolar disorder patient. So if you're looking at, I'll come to the specific question a little later before I discuss about this. Bipolar disorder people, do they have more obesity? Do they have more cardiovascular complications? And do they
yours is
have...
echoing, ma'am.
Yeah, I know.
It is
Not mine
echoing.
though. Is it mine that's echoing?
Maybe. Sir, Mittal, sir, maybe if we mute him, it'll be better. Sorry, sir. Yes, because the voice is echoing, so I'm extremely sorry. Please continue, ma'am.
So bipolar disorders per se, do they increase the risk for congenital malformations? Bipolar disorders per se, do they increase the probability of neurodevelopmental issues in the child, is something we should look at. So before we blame the medication, let us look at other associated risk factors. The first being primarily the psychiatric illness itself and the as varied comorbidities it brings along with it, one of the most common being substance abuse. So all of them will affect the development of the fetus. So let us look at, if you review literature, say I've reviewed a lot of literature from 2010 onwards, what it tells us is that mood stabilizer is the gold mood stabilizer, which is lithium, because of the ability to prevent relapses, because of its efficacy in both the poles, because of its anti-suicidal effects. However, the risk remains of whether I can use it in the first trimester of pregnancy. So latest literature tells us that abstinence anomaly, which we were all afraid of, is actually far overrated in older literature than what it is now. So now coming to our patient, if our patient is stable and had minimal episodes and could stay, and for the last 6-7 years, she never had any episodes, can I take a chance? Yes, maybe I can. But at what cost? Because the risk of relapse while on medication is also about 30%. So when you're off medication, risk of relapse in bipolar, especially in the first trimester, is almost about 80%. So when you're looking at a fetus in the womb, you're looking at two different exposures, one to the drug and other to the disease. So both of them are stressors, both of them are risk factors, and you have to decide which risk factor to go with. So since our patient has had multiple relapses and has a strong family history, she may need to continue lithium during pregnancy. Can we take a chance? But however, the paternalistic role of a doctor is no longer, acceptable. So it has to be in discussion with the patient. We have to tell them that 1 in 1,000 can get an abstinence anomaly. Are you willing for that? And if they're not, then we definitely will have to make a choice of an alternate mood stabilizer to be used. In my case, I'm more comfortable with using Q-tipin because of the same efficacy in both manic and the depressive features, and it's less transplacental, this one, and its safety in breastfeeding. I would like to go with Q-tipin. But if the patient has a high risk of relapse, I'd rather not expose her to the disease. I would definitely want to continue with lithium with proper education, because ultimately I have to save myself too, right? And then because the congenital anomalies, even if you're not giving a drug, even if the woman has no exposure to any kind of drug, the rate of congenital anomalies is 2 to 5%. And unfortunately, if your patient after taking lithium gets that congenital anomaly, it is immediately you and your drug that is blamed. So a necessary education is essential. So my mood stabilizer of choice, even if it is adolescent girl developing, would definitely be lithium. Valproate is a strict no, because anyway most guidelines are saying no. And possibly atypical antipsychotics could be one. Aripiprazole is recommended as a first line by many guidelines, but then the question remains, how many of our cases actually respond to aripiprazole? So if you're very fortunate, if sometimes our drug actually the patient responds to and has a good mood stabilizing efficacy with aripiprazole, I find that it often fails. In my experience, I find that it doesn't live up to its reputation many times. Yes. So all these factors need to be taken into consideration while we are choosing a prophylaxis for bipolar disorder.
Exactly. And especially while continuing lithium during breastfeeding, it is contraindicated.
Yes, it's contraindicated. Especially because you have to monitor the baby for side effects, and which mother will agree to, which mother will agree to a days-old baby to blood being drawn to monitor lithium levels, and it does cross the and it is secreted adequately into the milk to cause higher concentrations in the fetal circulation. So therefore, it is contraindicated.
Yes, ma'am. And especially when we are using antidepressants, antipsychotics, and mood stabilizers, even benzodiazepines in perinatal period. And while we are collaborating with the fetal radiologist and the gynecologist and pediatrician, what should be in our mind and what should we look for?
Yes. So putting all psychotropics together, whether we're looking at benzodiazepines, we're looking at mood stabilizers, antipsychotics, or antidepressants, including TCAs and SSRIs.
Yes.
When you start a drug, you start it for a particular indication. And if the patient continues to have good response to the drug, no matter what the drug is, of course, except for, say, maybe valproate or carbamazepine, you continue it even during pregnancy. You do not abruptly, suppose the patient is on paroxetine, which is only, in some meta-analysis, it's come out to be having some cardiac effects. But if the patient is very stable on paroxetine and responded best to that as compared to others, you do not abruptly take off paroxetine in the first trimester of pregnancy just because it will cause, and then put on sertraline, thereby doubly exposing the fetus to 2 drugs. Doesn't make sense at all. So you need to continue the drug. Whenever you are apprehensive that your drug may be causing certain congenital anomalies, you need to have a scan, preferably between 16 to 18 weeks, and therefore with a sonologist. I think our biggest barriers are the mindsets of the gynecologists we work with, who blame everything on our medication. Now, after having reviewed so much of literature, what I felt is a focus is unfortunately on the first trimester of pregnancy, where the focus should actually be going into the peripartum period. Where risk of neonatal adaptation syndrome, the floppy infant syndrome, though very transient and thankfully transient, the monitoring of the neonate needs to take place more there when we're using our psychotropics. So the various effects they'll have due to anticholinergics and all that. So focus definitely. What I believe is we need not really fear drugs for causing any major congenital anomalies. People still having doubts may refer to a 2021 review by British Journal of Psychopharmacology, where they followed up almost 120,000 pregnant women over a period of 10 years, and in a Finnish cohort, and they found that first generation antipsychotics, second generation antipsychotics, none of them had the congenital anomalies. Even when you read papers causing congenital anomalies, do read meta-analysis as well. where they tell you that though the relative risk is more when you take the drug in particular, but when you look at confounding factors, the mother's maternal illness, obesity, other medical illnesses, say gestational diabetes, drug use, when you put all these together, the contribution of the drug becomes negligible.
Exactly.
So let's not forget the other conditions which may be causing this. So focus would be on monitoring the baby around the delivery, especially when they're using our drugs, and a knee-jerk reaction of wanting to stop a very highly effective drug, thereby exposing the baby to the illness as a stressor, and also to double dose of polypharmacy later when the mother does not stabilize, is bad signs.
Yes. And like with paroxetine, there are outflow obstruction abnormalities, and with fluoxetine, certain gastro abnormalities. So do we have to give specific instructions to the radiologist to look into like fetal 2D echocardiography or any other like that, ma'am?
Yes, definitely. We need to do that. But what I'm trying to tell you is all these anomalies, like yesterday also in a group when we were discussing, today morning I think, when we were discussing, nobody wanted to come up with SSRIs as a first line of treatment for women with depression. It was TCS or sertraline. But when you look at recent meta-analysis, it says all this is because of confounding factors and not because of drug per se. So I think anomaly rule out should be done across pregnancies, and we need not be overly worried about giving our own drugs and worrying that they may be causing abnormalities.
Yes. And any specific instructions that we need to follow if the woman is inevitably on clozapine?
Clozapine, again, you have the risk, the benefits have to outweigh the risk, but then clozapine is relatively safe in pregnancy, but in breastfeeding, a strict no, again, because of the monitoring, and the same as lithium, that it's secreted in the breast milk, and the monitoring of the baby. I'm not even sure whether we have such monitoring facilities, and if we do, are the mothers willing to get it done? I've never used a lactating mother.
Right. And forwarding to the next question, like coming to the perimenopausal depression as such. So it is one of the most underdiagnosed or rightly said underreported condition. So here, how do we choose our drug choices, like between antidepressants versus HRT, because perimenopausal depression is identified because of the fluctuating levels of estrogen or lower levels of estrogen. So is HRT better, or is antidepressants, because they are the FDA approved medications for perimenopausal depression?
Yes.
So what would you say?
Perimenopausal depression, perimenopausal period for everybody's relearning is about 5 years before they start the menopause to a few years later. And this is time for all hormonal fluctuations to take place. Now, depression at this level also is treated as depression, and like we do a depression in our, and generally MDD at any stage of life. Exactly. However, HRT is found to be HRT when given to normal women without any mood disturbances did not show any adverse effects on the mood. HRT when given to women with depression showed a response when they were associated vasomotor symptoms like hot flushes and sweating and palpitations and all that. So is it the role of HRT on the vasomotor symptoms which is causing an improvement in the mood is what we need to understand. And HRT also can have neuroprotective, cardioprotective, mood-enhancing properties, but that should be given in the perimenopausal or early menopause phase so that the estrogen receptors are still receptive. So giving it, say, 10 years down after post-menopause will not be effective at all. So treat perimenopausal depression as, of course, with the various psychosocial interventions that need to take place and various medical comorbidities that need to be ruled out and treated. But SSRIs or its congeners continue to remain the first choice, except when vasomotor symptoms, except when you're using HRT for specific indications like vasomotor symptoms. And of course, you have to keep in mind the various contraindications like breast cancer or thromboembolism and all that, which they tend to, they are in risk factors for.
Exactly. So thank you so much, ma'am. I end up my questioning over here, and I hand it over to our chairpersons for the further.
Can I just ask two questions, Dr. Sri Lakshmi?
Yes,
regarding the lithium and the clozapine. like you said that, I mean, if we could give it in the pregnancy, but during breast feeding, it is contraindicated. So in that case, should we start a drug which we have to later discontinue? Or is it better that we start the same drug which can be continued even during breastfeeding?
That would be the best option, ma'am. Always the best option. But suppose the person is, if you have the luxury of actually starting a drug during pregnancy, that's a different thing altogether. So why do we want to start with a lithium? But if the person is already on, say, lithium and continues to be, and then we know that every time the lithium was stopped, the response has been worse. We will have to take a chance and continue with lithium, and then stop the breastfeeding, hoping that it's not a premature baby, because then the baby also, then the struggle becomes even more for the treating doctor. But yes, ma'am, like you said, is the alternate way of thinking, that if you can think of a drug which will be good in pregnancy, which will be good in breastfeeding, why not start with that? So, and the ideal patient is a patient who comes to you 6 months before planning pregnancy and says, I want to get pregnant. So you have all the time in the world to make our changes. Unfortunately, doesn't, like you very well know, ma'am, that it doesn't happen that way.
And another thing which I would like to add is that you said we have to psychoeducate the patient, but more important than that is that we have to document what we have educated.
Yes, of course. Yes, of course. You're very right, ma'am. You're very right.
So, I mean, are we going to play the this of Dr. Talk of Dr. Satya Malhotra, or still there is?
Ma'am, we have 10 more minutes. We can go ahead and play the presentation. Yogesh?
Yes, ma'am. Just 1 second.
Good evening, friends. It's my great pleasure to be with you all today evening at this CME organized by IAPP and Bombay Psychiatric Society. My grateful thanks to Dr. Ruksheda, Dr. Hina, and also the office bearers, Dr. Anukant Mittal, Dr. Avinash D'Souza, and all other office bearers of IAPP and Bombay Psychiatric Society for giving me this opportunity to be with you all at this CME. We are focusing today on women's mood disorders seen in women, and I am required to talk about pharmacotherapy of mood disorders in women across lifespan. I would like to start with my screen share. Yes, I think there it is. You can see my screen now. Okay. So pharmacotherapy of mood disorders in women across lifespan. I'm sorry I'm not being able to join live today and sending you this recorded message. Okay, how do I move further? Move the next slide. Okay, here. Yeah. Mood disorders are common conditions. We know major depressive disorders and bipolar disorders, they are commonly seen among women, and they have to be treated, and treatment is essential because they cause significant amount of morbidity and difficulties and disruption in the life of women and families. Unfortunately, women, particularly in the reproductive age group, and those in the adolescent age and old age have been often excluded from research on treatments. So various treatment methods and drugs that are tested for treatment of major depression and bipolar disorders, usually women have been excluded from this, and particularly women who are pregnant or who are lactating or who are in the in the adolescent age group or old age group. So they are a sort of research orphans, and not much is already known or researched with terms of pharmacotherapy in these groups. And therefore, all these guidelines that are there already, the research evidence that is there, may not directly be applicable to women. And there is this warning always issued that it has not been tested in these groups. So therefore, we have to be very, very careful about special considerations that have to be looked at and considered while prescribing pharmacotherapy to women. And we know that there are gender differences in metabolism of in metabolism across in women and men, and there are hormonal changes across lifespan that occur, and they affect significantly the manifestations, presence, and also the handling of medication in women. pregnancy, childbirth, lactation provides another specific areas that need consideration and looking at. And then we have to also look at severity of the disease and comorbidity, which is very, very common in mood disorders in women, particularly they have with mood disorders, anxiety, phobia, panic, or may have migraine, may have thyroid disorders and ADHD. And so all these conditions also kind of complicate the treatment decisions that are taken for women with mood disorders. We have to, in all situations and circumstances, weigh the risk and benefit, and also discuss the treatment decisions with the patient and family before prescribing. There are gender differences seen in prevalence, clinical presentation, and treatment response of seen in women and men. We know that the depressive disorders are more often and more prevalent seen in women, and female to male ratio is about 1.7. And mood disorders, depression is seen across life cycle from adolescence to midlife to old age. And in depression, women present with greater number of symptoms, and they also present with more often reverse vegetative symptoms like hypersomnia or increased weight or increased appetite and so on. Suicidal behavior is seen often, and it starts from early adolescence. And then, as I already said, that they have more often comorbidity, and there are several precipitating factors associated with the reproductive life cycle related issues in women, and they are more sensitive to stress. They are more prone to seasonal changes in manifestation of depression. And when we look at influences across the life cycle, we find that in adolescent and teenage, the risk for suicide is higher with antidepressants in adolescent and teenage group. And in childbearing age, when there is presence of perimenstrual mood symptoms, this points towards the possibility of full-blown depression later on. Perimenopausal women, if they have vasomotor symptoms, that indicates occurrence of depression later on. And vasomotor symptoms, they signal presence of dysregulated hormones and neurotransmitters. And post-menopausal response to antidepressants, it depends on presence of HRT. So we have to be very careful while prescribing medication in post-menopausal women. If they are on HRT, then there have to be treatment decisions have to be modulated accordingly. Across lifespan, when we look at the handling of the drug and treatment response and medication tolerability and pharmacokinetics, that varies in women across lifespan. And there are changing levels of estrogens across lifespan. They influence the neurotransmitters and neural proteins. They alter the risk for depression, and not all treatments are effective at all times. Looking at pharmacokinetics, there are differences in drug absorption, bioavailability, drug distribution, drug metabolism, and elimination. Women have slower gastric emptying time. They have lower gastric acid secretion, higher percentage of body fat. They have decreased hepatic metabolism, decreased renal clearance. Therefore, women have higher plasma levels of drugs. They have longer half-life of drugs and greater sensitivity to side effects of drugs that we prescribe in them. Medication levels in women are altered by hormonal changes associated with menstruation, pregnancy, childbirth, oral contraceptives, and HRT. So we have to be actually careful about all these aspects while prescribing drugs to women. Women respond better to SSRIs and MAO inhibitors as compared to tricyclics, and particularly perimenopausal women, they respond more poorly to tricyclics than sertraline. And several studies have shown that women are at greater risk for recurrence of depression than men. Augmentation with triiodothyronine is more beneficial in women than in men. Estrogen replacement therapy may enhance response to SSRIs in postmenopausal women. Lithium and stimulants may be more beneficial in women than in men. Hormonal contraceptives may be rendered ineffective by concomitant use of psychotropics which induce their metabolism. For example, if a patient is on carbamazepine, carbazepine, topiramate, modafinil, these are enzyme inducers, and they can make the oral contraceptive, hormonal contraceptive ineffective by inducing the enzymes. So women who are on oral contraceptives should be encouraged to take at least those ones which have at least 50 micrograms of estradiol when they are to be prescribed mood stabilizers. Estrogen containing contraceptives might reduce lamotrigine level by about 40 to 60%. So therefore we have to give higher doses of lamotrigine in such cases. We have to also see the risk of treating and not treating pregnant women and risk of treatment on fetus. These are very, very important considerations. Risk of non-treatment can cause relapse, and that has its own complications applicable to the mother and also to the fetus. Most antidepressants are classified as low risk to fetus during pregnancy, but they are potentially toxic for breastfeeding. We know that the paroxetine can cause cardiac malformations, and valproic acid can cause neural tube defects. SSRIs in third trimester can cause PPH, and also SSRIs can cause neonatal withdrawal syndrome. So these considerations have to be always kept in mind while prescribing drugs in the pregnancy. Prematurity, low birth weight, long-term neurodevelopmental abnormalities are seen in patients who are prescribed antidepressants, and we have to, while treating depression, weigh the risk and benefit. Women are more prone to depressive diathesis. Now coming to bipolar disorders, women are more prone to depressive diathesis of bipolarity. Even in mania is mixed with depression. They have more often depressive episodes with bipolar disease. Depressive episodes in women are longer and more resistant to treatment, and they have the later age of onset. And more often in bipolar disorder, women have rapid cycling and seasonal pattern. And more often, these are comorbid with anxiety, substance use, and eating disorders. Migraine and thyroid disease is also comorbid with bipolar disorders in women. So while looking at treatment for bipolar disorders, management of rapid cycling and mixed affective states is very, very challenging in women. Carbamazepine and valproate are better in managing rapid cycling. Clozapine and olanzapine are effective alone or as adjunct. Addition of levothyroxine improves mood stabilization in rapid cycling. There's limited data on hormone use in bipolar disorders in women. Olanzapine, clozapine, quetiapine are better tolerated as compared to risperidone in treatment of bipolar disorders. And valproate and lithium, they do not interfere with efficacy of oral contraceptives, so they are relatively safer and neutral. Lithium in bipolar disorder remains the gold standard for treating recurrences, for treating mania, both recurrences in bipolar disorder 1 and 2, and it also has anti-suicide effects, and lithium is effective in several studies in pediatric bipolar disorder also, and has been recommended by FDA for use in 7 to 17 years age group. Twice daily dosing is recommended in pediatric age group for bipolar disorders because of rapid renal clearance. Side effects include changes in blood counts and neurological side effects.
Admins will need to
lithium during pregnancy and lactation. There is high risk of cardiac and other congenital abnormalities that is reported with use of lithium in bipolar disorders. Discontinuation of lithium, on the other hand, in pregnancy can lead to relapse, and that is another risk, and one has to weigh the risk and benefit. We try to avoid lithium during first trimester, and the effect on babies feeding on lithium mothers is not well researched, but most guidelines conclude that there is a negative benefit risk ratio for breastfeeding during lithium treatment. But there are also reports to say that the babies born to mothers taking lithium have been without any congenital malformation or complication. Lithium is recommended in old age in bipolar disorder as first-line treatment. Lithium and valproate are both effective in prevention of bipolar disorders. Low doses of lithium are recommended in old age. co-prescription of lithium with ACE inhibitors, angiotensin inhibitors, NSAIDs. Now, these are the drugs which very often old age people in old age are prescribed and are taking, and is to be done. The co-prescription of lithium is to be done with care. Now, when we look at bipolar disorder and its relationship with the reproductive life cycle, pre and perimenstrual exacerbation of mood symptoms often occurs. There is exacerbation of mood symptoms in the pre and perimenstrual phase. Lithium and valproate are ineffective in premenstrual syndrome. Pregnancy is risk neutral in women with bipolar disorder, so it neither decreases or makes or increases the risk of bipolar disorder. Relapse can occur on sudden discontinuation of mood stabilizers if the patient is already on taking medication and suddenly during pregnancy you have to stop it, then there is a risk for relapse. Maintenance medication can be discontinued in pregnancy if there is a low risk of relapse or if there is a mild disease. If there is a moderate illness, try to stop medication slowly with good surveillance. In severe form of disease and high risk of relapse, it may not be possible to or advisable to discontinue treatment during pregnancy. Lithium, carbamazepine, and valproate are teratogenic, have teratogenic effects. Olanzapine is indicated in short-term treatment of acute mania. We must choose medications that have low teratogenicity and neonatal toxicity. Choose lowest doses possible, and you try to stop medication in first trimester and may start later if required. As much as possible during the first trimester, try to stop medication, weigh the risk and benefit, and discuss treatment decisions with the patient and the family. In the postpartum phase, though no psychotropic is absolutely safe for breastfeeding, but there are several studies that indicate safety of antidepressants like TCAs and SSRIs. Lithium is contraindicated during breastfeeding. Carbamazepine is unsafe in breastfeeding. We have to again, emphasizing time and again, weigh the risk and benefit for possible relapse. If mother does not want to risk the infant with exposure to medications, then we must stop lactation and go for top feeds. There is limited data on use of mood stabilizers, MAO inhibitors, mirtazapine while breastfeeding. It is better to use lowest effective dose and minimum number of drugs during lactation phase. Patients who are already on antidepressants with high risk of relapse should be maintained on medication during pregnancy. There is more experience reported with amitriptyline, imipramine, and fluoxetine, so it may be better or preferable to choose any one of these drugs. Avoid paroxetine. Avoid drugs as much as possible during first trimester. Use smaller doses in elderly, and risk of hyponatremia with SSRIs should be carefully monitored. So in conclusion, as I started off with, the treatment of bipolar disorders and major depressive disorders is essential in women across lifespan at all ages and stages. Women have been kind of research orphans and have not been well studied with regard to the safety, efficacy, and the guidance about the use of psychotropic drugs. So all these considerations have to be kept in mind, and treatment decisions have to be taken accordingly. We must discuss treatment decisions with the patient and the family and weigh the risk-benefit ratio at all times. Thank you very much. Thank you. I stop here. Thank you very much.
I thank Dr. Savita Malhotra, ma'am, though she is not present in person, for her lucid talk. And now if there are questions, the moderator can take them up.
Yes, ma'am.
I can see just one question. Who's more worried or who gets mentally fatigued easily, working women or housewives?
Housewives are also working women, ma'am.
I
know. They work in a different environment, that's all.
Yeah, they are the most stressed ones, if I may put my two bits.
I think there are no more questions.
Yeah, I don't see any questions
yes,
here.
Neither do I in the admin box. I take this opportunity to thank all our three wonderful speakers. Savita ma'am, even though she's not been here, Dr. Shweta Reddy and Dr. Sri Lakshmi ma'am. Thank you so much for conducting this session. I would also like to thank our chairpersons, Dr. Anukan Mittal and Shashi Rai madam. And with that, I would like to request my organizing chairman and a dear friend Rukshida to kindly deliver the vote of thanks.
Thank you so much, Dr. Hina. It's been a enriching, lovely evening, albeit a little tiring maybe for most of us. I apologize for that. But because we have credit points, we also needed the certain number of hours to conduct the session. And I see that a lot of us, at one point, we had more than 350 people, active users, listening to the presentations today and the deliberations today. I cannot thank the audience enough for being patient with us and being, and listening to all our learnings and sharings. That's how we grow, not only as physicians, but also as a community and as a country. So I, at the outset, like I said, thank you so much to the audience. Without them, we wouldn't have been able to do this. When we look at mood disorders, even if we just look at the depression, the overrepresentation of women with mood disorders, if we lower that, we can definitely reduce the global burden of disease, isn't it? So I think this is, a wonderful opportunity for us to learn and improve on our clinical skills, our biological understandings of the underpinnings of mood disorders, and of course, the psychopharmacological aspects of it. And it was very fortuitous, isn't it, that we ended the session with Dr. Savita Malhotra, because I think she kind of rounded and encapsulated the entire evening so succinctly in the 10 minutes that she had. So we are ever grateful for her. And of course, all our other speakers, and, Dr. Pingle, Sri Lakshmi, most impressive with her Q&As, and Dr. Shweta worked very hard on the questions, and I think gave us a lot of different kind of approaches towards women mental health, mood disorders of cross span. I cannot thank them enough.
Thank you.
My like I said at the beginning, I've just kind of delegated things and I get all the laurels. So I'm very happy for all of these team of amazing women, especially, but also so ably supported by our president of IAPP, Dr. Anukan Mittal, who's always very supportive and encouraging and has never said no for any idea that we had. And also Dr. Avinash D'Souza, who's, just said yes to everything that we've requested him of, including conducting the session with the residents. And I'm so proud of our residents, Dr. Shahrukh, Dr. Dr. Saili, Dr. Madhura. They presented wonderfully well. And I think it was ingenious of, Dr. Avinash also to rope in different residents from different hospitals from our Mumbai BMC. Of course, the motivational interviewing is such an important aspect of such a good clinical tool that we might have when we are working with women, especially. So we are thankful to Mrs. Joshi for doing that. And of course, Dr. Bhaskar started off looking at neurobiology and connecting it with clinical presentations so wonderfully, really. So I cannot really thank all the speakers and chairpersons. Dr. Hina Shah's been superb and so easy, because unfortunately our other chairperson for today couldn't make it due to last minute personal emergencies, but she so ably guided us through all of that. Definitely a huge shout out to Hina, because like I said, I call her partner in crimes, but actually she's the one behind doing all of this and given us an opportunity to learn with each other and grow. Sun Pharmaceutical has always been very, very generous with the unrestricted, academic grants, and especially Yogesh and Subedar have done a wonderful job, and they were always very, very kind to me. So it's very sweet of them to put together all of this. And even the Sun Pharma people from Punjab, they were so great about helping us videotape Savita Malhotra ma'am's presentation today. And of course, not the more, I'm going to save the best for the last, Dr. S.R. Parker. She has been diligently been here and, observing all of us. She's the FMC observer for tonight. And as you can see, it's 10:15 and all of us maybe wilting, but definitely not my teacher, Dr. S.R. Parker. Madam, so thank you so much for joining us, and thank you so much for observing us. And, hopefully all of us have those CME credit points. And we, you can report that we were very honest and efficient and obedient about following all the MMC guidelines. Thank you so much. And with that, I must thank again Dr. Shashi Rai ma'am and Dr. Shweta Reddy, who are my team members at the IAPP Women's Mental Health Committee. With that, I hope I haven't missed out anybody, excepting for God and parents, but I think that's always included under our breaths, isn't it? So thank you so much. We hope that we haven't delayed your dinner too much, and it's been a lovely evening, and hope to see you guys again next year. Bye. Good night.
Bye, and a big thank you to you also for putting all the whole thing together.
No, ma'am, like I said, I just delegate. I'm the queen of delegation.
That's an art.
Shweta, thank you very much for your very incisive question.
Thank you, sir. Thank you.
Very precise and incisive.
Thank you.
Thank you, everyone. It has been amazing. I'm hoping to meet some of you in person. Once again, thank you so much. And with that, I think I will leave this meeting now. All of you have a good evening.
Good evening and good night, all of you. Have good dinner.
We have Dr. Nyanwin Kwa. I'm so sorry if I'm mispronouncing your name. He's joined us on. Oh, I'm so sorry. I apologize. I'm not familiar with the language. He's Myanmar along with some other of his colleagues. I wasn't sure that you're still here, sir. Otherwise, I've asked you to share a few words. But please, if you could give us your feedback, that would be really.
It's a very, very good and very informative and very illustrative presentations. And my juniors also attend this Zoom webinar, and I'm very pleased to be here and to listen and watch a very good presentation upon women's mental health. Thank you.
Where are you from, sir? Where are you from?
I'm from Myanmar.
Sorry?
Myanmar, sir.
Myanmar.
Okay.
Yes.
Thank you, sir. Welcome.
Night.
Bye-bye.
Good night.
Good night. Parker, madam, thank you so much.
Hello, ma'am.
Hello, ma'am. Thank you so much. I was very relieved when I got to know that you are our MFC observer. Ma'am, from my end, I have sent everything, ma'am. The BPS team will get in touch with you, all the documents and everything, and hopefully we'll get our credit, ma'am.
Ma'am, unmute yourself. You're muted.
Ma'am, you're...
Yeah, of course we will get credit points, but seminar was wonderful.
Thank
Beautiful.
you, ma'am. Thank you so much. It means a lot, ma'am, coming from you.
Yes.
Thank you, ma'am.
Right.
Thank you and good night.
Yeah.
Thank you, madam.